Good morning, everyone. We'll start our Healthcare Advisory Committee meeting. And good morning. The meeting will now come to order. Please note that this meeting is being recorded. Appreciate you being here. Hope folks enjoyed their long weekend and celebrated Dr. King's birthday yesterday. We will start with a roll call, and I'll turn it over to Karen Bloomer for that.
Thank you so much. Good morning. Okay, in alphabetical order, Joan Allen.
Present.
Barry Arbuckle.
Present.
Eliza Arjoyan. Katie Basler. Stephanie Klein. Carmen Comsty. Adam Doherty.
Present.
Parker Duncan Diaz.
Here. Good morning.
Hector Flores.
Present.
Present.
Stacy Hrontes.
Present.
David Joyner. Travis Lakey. Tam Ma. Carolyn Nava. Mike O'Day. Janice O'Malley. Mariel Reataza.
Present.
Sumana Reddy.
Present.
Yolanda Richardson. Christina Rodriguez.
Present.
Karen Savage Sangwin. Andrew C. Stephen Shortell.
Present.
Sarah Sorokin. Ken Stewart.
Present.
Suzanne Usage.
Present.
Renee Williams. Abby Yount.
Here.
Thank you. That completes roll call.
Let's see. I see that we have a couple of advisory committee members who are online. So Hector Flores, did we get, he said he was here. Terrific. Okay, wonderful. So if you are joining remotely as an advisory committee member, we do ask that you have your camera on. And I hope that we have on with us our attending board member, Richard Pan. Dr. Pan, are you with us? Thank you for turning on your camera, Dr. Flores.
I am.
Richard Pan. Dr. Pan, are you with us? Terrific.
Yes, I am.
Wonderful.
Can you hear me?
Thank you
Yeah.
so much.
Do I
Thank
need
you,
to leave my
Dr.
camera
Pan.
on at the
Welcome.
moment? Okay, thank you.
You're not required to have your camera on, Dr. Pan, so we'll leave that up to you.
Okay.
We appreciate you being with us. So Richard
you.
Pan, as a member of the Affordability Board, is here with us virtually. And as you know, we have a board member with us for every advisory committee meeting, and their role is to listen to the presentations and discussion and help convey your input to the board. So the staff always does a pretty thorough job conveying the themes of your input to the board, and then we have a board member who can add to that, which we very much appreciate it. I'm also joined today by Karen Bloomer, who's helping us with some facilitation, and Jean-Paul Buchanan, who is here as a member of OCA's legal staff, as well as, of course, many wonderful OCA staff members who will help us with the presentations today. And so we'll start with going over the agenda slide. And so, as always, we have a very rich and full agenda for you all. So if we could move to the agenda slide. So after updates from myself and Vishal, we will hear about upcoming changes to the data submission guide. Then we'll talk about sector target options that the board is considering. Due to the fires in Los Angeles, we won't be hearing from Altamed. That was to be item 5, and so we'll be putting off that presentation on cost reducing strategies to a future advisory committee meeting. Let's see, Vishal, do we know who's advancing slides? All right, so we'll get the slides sorted out. Here we go. Thank you so much. And then we have presentations. We'll have a discussion about sector target options. And then we have presentations about cost and market impact review program. We give updates to you as well as the board about that, as well as updates and presentations on our equity and quality measures and on the behavioral health benchmark. So that's our agenda together for today. Okay, moving on to executive updates. And I'd just like to start by saying that our hearts are very much with all of those who are impacted by the devastating fires that have been occurring in Southern California. Secretary Johnson was there all last week on the ground with different parts of California's response team. The governor's been on site very much on the ground, you know, at food closets, with CAL FIRE, with all of the response levels. And we within the administration are working to provide every level of support to those affected, working alongside our city, county, federal, and nonprofit and other partners. Of course, we know that there are very serious health impacts for those impacted, people who had to evacuate without their medications, without their medical supplies or equipment, those impacted by the smoke and other health hazards. So at HCI, we've been tracking the 11 skilled nursing facilities that had to be evacuated. One was destroyed completely. Another suffered severe damage, really harrowing situations that those SNFs had to be evacuated. Several are repopulated or in the process of doing so. Our HCI facility staff inspect those buildings and green tag them before they can be repopulated. We know there are many, many other impacted facilities. We know many clinics had to close, residential treatment programs, congregant living facilities, child care centers, elder care centers, schools, and you all know this, that the list goes on. So we want to recognize the destruction of the fires and the pain being felt by many in our community, and frankly, the need for both practical support and also mental health support. And we know that's going to go at some length in the weeks and months to come as those who lost their homes and others were impacted grapple with the impacts. So again, HCI field staff are focusing on SNF repopulation efforts. Fortunately, none of the general acute hospitals themselves had to be evacuated. They defended in place and we're monitoring. So our staff is doing on-site facility inspections. Medi-Cal has simplified enrollment and renewal processes and procedures to get Medi-Cal members their prescription drugs and medical equipment. The state is working closely with behavioral health plans and local programs on access to needed behavioral health services. Department of Managed Healthcare has directed health plans to assist impacted members in easily accessing services including prescription drugs, and DMHC has published a resource guide. California has also received federal approval for an emergency prescription assistance program, and that helps folks in federally identified disaster areas who don't have health insurance access prescription drugs and equipment and vaccinations and the like. So there is information about all of this and many, many other resources on a website that was just set up specifically for the LA fires. So it's www.ca.gov/LA fires. So there are a lot of resources available. We know there's a lot of need there. We tried to take an equity approach in all the work that we do. And so as we look at the fire, we acknowledge the Eaton fire destroyed a historic Black neighborhood in Altadena. Over the years, Altadena was a haven for Black families who were prevented from buying property in Los Angeles and Pasadena due to redlinings, right? So we very much continue to see the impact of racist policies and how that impacts who can buy properties and build communities in what places. So many Black families built in the 1960s and built a thriving, diverse middle-class community that they hope would become a source of generational wealth for their descendants, and many of those homes are now gone. Many of those homeowners are worried they won't be able to rebuild in the same area, spelling the end to a beloved community. So we're keeping in mind all communities and the need to be intentional about providing equitable access to disaster recovery. So we're very much thinking about those in immigrant communities who may feel frightened today to come forward to seek resources that are available to them. We're thinking about the need for language access and to provide services in many languages. We're thinking about the need, the particular needs of older Californians and those with disabilities. So there's a lot happening within the Health and Human Services family to try to provide support. We know you and your organizations are also doing a lot, and so appreciate that collaboration as we respond to the fires and work toward our recovery efforts. But deadlines still come and go. So in the midst of the fires, the administration did release our 25-26 proposed state budget. On January 10th by Joe Stippenshaw while the governor was on the ground, the director of Department of Finance. So it's a $322 billion budget. And last year, the governor proposed a 2-year budget framework, including reductions. And so because of that 2-year framework, there are not proposed reductions in this year's budget. There are actions that were taken this year that allow, that provide some savings ongoing, including the elimination of 6,500 state positions and operational cuts of almost 8% that impact OCA and HCI, as well as most other state departments. So, we are directly impacted by those cuts. Other budget components impacting HCI include BH Connect, and I definitely cannot remember this acronym, so I'll read it out. So BH Connect is a Medi-Cal waiver, stands for Behavioral Health Community-Based Organized Networks of Equitable Care and Treatment. Who came up with that? So under the BH Connect demonstration project, which was awarded in December of 2024, this is a focus on our Medi-Cal behavioral health network. So the BH Connect includes statewide and county components to expand and strengthen the behavioral health continuum for Medi-Cal members living with a significant behavioral health condition, with a focus on children and youth, individuals experiencing or at risk of homelessness, and justice-involved individuals. HCI's component is within our workforce program. So under the waiver, HCI is eligible for up to $1.9 billion over 5 years to support development of the behavioral health workforce, and we know that's very much needed in California. So because the waiver wasn't finalized until December, we'll have a spring BCP budget change proposal for BH Connect, and we're very excited about the meaningful impact we'll be able to have with that level of funding. Also very excited that the budget includes long-term funding for the HPD, the Healthcare Payments Data Program, or California's all-payer claims database. So when the HPD was created by the legislature in 2018, we were given a one-time appropriation that's gotten us to this point, but now it's time for a sustainable funding source. So the budget seeks $22 million per year ongoing, and 47 staff positions to continue this critical data program. And I'll have a few updates about HPD in just a minute. There's also a legislative BCP for implementation of the hospital seismic safety and clinic building standards. So the governor signed bills which allow some hospitals an extension to comply with seismic safety standards with an approved compliance plan. There's also some changes to building standards for clinics not connected to a hospital and some staff positions to implement that work. On the theme of affordability, there's a new diaper initiative proposed in the budget. The governor is proposing to provide a free 3-month supply of diapers for all California families with newborn babies to help improve maternal and newborn health outcomes. And so the budget calls for HCI to administer this initiative, knowing as we do that diaper affordability is a significant concern for many California families. We also know, of course, that prescription drug affordability continues to be a huge strain for many Californians. And so the governor has charged HCI and some other state agencies to work on a proposal to try to both get better transparency and understanding about prescription drug cost drivers, and also some proposals to improve the affordability of prescription drugs in California. So as always, this is the beginning of a budget process. This is a proposal. We face more uncertainties this year than many, given the change in federal administration. That adds to sort of the risks and uncertainties that we're tracking as we continue the budget discussion within the legislature. Okay, the fires, the budget, and then last, I'd like to provide some updates about the HPD and where we are. So reaching a really big milestone, the HPD data release program began accepting applications for requests for access to non-public HPD data, right? So the HPD has been built, we've started publishing public data, and now for the first time, researchers, agencies, folks can come forward and request non-public data. And so we had a webinar about that application process last week. I'm told we had 175 folks on, so it's pretty robust interest. Some of you may have been on that call, and so we're really excited to have this rich data source be used. And we will be publishing answers to all of the questions that were posed on that webinar. This Thursday, in 2 days, we're back upstairs for the public HPD advisory committee meeting, on which several of you sit, and we'll focus on looking ahead at strategies for 2025, including a discussion of the provider organization index pilot project and use cases related to benefit design. HCI's OCA and HPD teams are planning to co-present to the OCA board in March about how staff are using HPD. So that will be in a couple of months. So that's a lot from me, and I will turn it over to Vishal Pagani, and then we'll have an opportunity for you all to ask either of us questions or make comments in just a minute. Thank you.
Thank you, Director. I'll be providing an update on a few items. First, OCA is sharing our quarterly work plan. This month, OCA will present the following items to the board pertaining to total healthcare expenditures and spending targets. The board will discuss options to define hospitals as a sector and may take a vote at the January 28th meeting. After this vote, OCA will need to follow up with the board in February with regulations that would effectuate the board vote on sector definitions. Later today, we'll cover more specifics on that timeline. In January, OCA will provide further data analysis on hospitals to inform a target setting methodology, and will provide a staff recommendation on hospital sector target values on or before February 21st. At both the board and AC meetings this month, OCA will discuss the draft revised data submission guide and accompanying regulations. Public comments will be received until January 31st, and we'll take those public comments and revise the data submission guide further based on the feedback. The goal is to obtain approval on this regulatory package later this spring. Lastly, the board will vote this month to establish a subcommittee to consider reappointment of AC members and selection of new members. Shifting over to the CMIR program, both the board and the AC will receive the quarterly update on notices received under the program. Moving on to promoting high-value system performance. In today's meeting, you'll receive an update on OCA's proposed quality and equity measure set, and an update on the behavioral health investment benchmark. Your feedback will inform the presentations we make to the board on these topics in next month and March. And now on the next slide, we've proposed future topics beyond March. A key activity will be continued discussion on and board action on sector targets, the behavioral health investment benchmark, and the quality and equity measure set. We also hope to introduce the topics of equity and quality adjustments as they pertain to spending targets and spending performance. And then lastly, you'll receive another quarterly update in the spring on the CMIR program. I'll now move on to our spring process for advisory committee member selection, which includes both reappointments and selection of new members. Next slide. So you'll see highlighted in yellow the AC members whose term will end this coming June. Highlighted in yellow. On the next slide, we've laid out our timeline for selecting new members, including reappointments. After the board votes on the subcommittee later this month, we'll open a submission process from February to April. During April to May, the subcommittee will review and select members, and the goal is to have the board discuss the subcommittee's recommendations and approve new appointments and reappointments at the June meeting. This will ultimately result in the new members attending their first meeting next September. And now moving forward, I'd like to highlight key findings from the latest CMS report on national health expenditures. In 2023, healthcare spending reached a high of $4.9 trillion, amounting to an average of $14,570 per person. This represents a per capita growth rate of 7% in 2023, which was substantially faster than the growth rates of 4.2% in 2022 and 4% in 2021. The largest contributor to this growth was private health insurance spending, which increased by 9.7%, reaching $7,065 per person. This marks a sharp rise compared to the growth of 5.1% in 2022 and 6.8% in 2021. This sub-bullet here notes that the net cost of private health insurance, which is a term that encompasses administrative expenses, taxes, and fees, grew by 12.5%, which further drove overall spending increases in the private health insurance sector. Going on to Medicare spending, this Medicare spending accelerated, growing by 5.9% to $15,808 per person, compared to a 4.4% growth rate in 2022. This growth was bolstered by the continued expansion of Medicare Advantage enrollment and higher spending on hospital and prescription drug services. Medicaid spending per person saw even sharper growth, increasing by 7.1% to 9,000, which translates to $9,502 per person, a significant rebound from just 2.1% growth in 2022 and negative growth in 2021. And then on this slide here, in 2023, the insured rate reached a record high of 92.5%, the highest level in 6 years. This milestone was driven by strong enrollment in both private insurance and Medicare. The growth in spending is not solely tied to coverage expansion. Increased utilization and intensity of services also played a substantial role. Healthcare prices rose by 3.3%, consistent with 3.1% observed in 2022, but higher than the average annual growth rate of 2%, which occurred from 2016 to 2022. And then when we look at breaking down spending by categories, hospital care, which represents almost a third at 31% of total healthcare spending, grew at a remarkable rate of 10.4%, a significant acceleration compared to 3.2% in 2022. This is the fastest growth in hospital spending since 1990. Physician and clinical services comprise about a fifth, at 20% of total spending, increased by 7.4%, up from 4.6% in 2022. Meanwhile, prescription drug spending, which accounts for 9% of total spending, rose by 11.4%, surpassing the roughly 8% growth we saw in 2022. So in totality, 2023 was a year of accelerated healthcare spending growth, driven by a mix of increased insurance coverage, higher service utilization, and rising prices. These trends underscore the challenges of balancing access to care with affordability. And then lastly, I just want to remind the advisory committee members, as well as members of the public, about our slide formatting. We'll use a blue arrow in the presentation for areas that the advisory committee provides input or recommendations on based on statute, and other areas as requested by the board or OCA. Now, I'll turn it back over to the facilitator to facilitate a discussion among the members.
Any questions? Simona Reddy.
I just wanted to thank you for the report on the LA fires and just like the heart around things like diapers that, you know, this state, it's a lot right now, and it's just very heartening to hear that. I wanted to throw out a very quick resource for clinicians, all clinicians, and their supporters. In the Sonoma fires, 2 doctors struggled to bring order to, you know, public gym, like how do you do healthcare? So if you Google disaster crash cart familydocs.org for the CAFP, there is a incredibly useful resource that's just from beginning to end, how do you set up and provide clinical care in a disaster? So I think all of you might want to know about that.
Thank you. And online, Stacey Hurantes and then Stephen Shortell.
Good morning. Just a comment about the data and looking at the time period when we had the COVID pandemic, because we did observe utilization going down during the pandemic for a couple years, and then it shot back up. So perhaps a view of pre-COVID, looking at the trend in expense change, as well as the supply shortages in terms of pharmaceutical costs, staffing costs, and that those other aspects would be, I think, interesting to consider as well.
Thank you, Stephen Shortell.
Yes, I want to thank you, Elizabeth, for acknowledging all the suffering going on in Southern California. My mother-in-law, she's now deceased, but she lived in the fire was within a block of her home, but the neighbors and some of her relatives were devastated by it. They're physically safe, but not their homes anymore. I just wanted to comment a little bit, and maybe provide a little bit of information that underscores what Vishal's update is on the spending and so on. And this is for, you know, the OCA board. We're advisory to them, and I'm glad Dr. Han is with us also virtually. It's just a reminder that we all know about prices, right? The prices are high in the United States, California. We also know that consolidation appears to be associated with higher prices and all of that. But also utilization, and this, you know, utilization and the intensity is a big factor as well. And in particular, I just don't know how much discussion in the OCA board so far, and I've missed some of the meetings virtually and so on, has been around low value care spending. Low value care spending, which is estimated to be roughly between $100 and $700 billion in the United States. And just to flesh that out a little bit, and maybe this is staff can do more work on some of this, it's estimated to be up to about 40% of spending in Medicare is low value. About 15% for Medicaid, 11% for commercial. Now those are national figures. I don't know what the data are for California. We could try to look at that. So one thing is, over the last 10 or 15 years, a bunch of clinical committees have defined what a low value service is. There's about 26 of them. Sometimes it goes up to 40. There's honest debate about what's low value or little value or no value or even harm, but they can be grouped into about 6 categories. And one of them is cancer screening. Another is diagnostic screening, preoperative screening. A lot of the lab tests before we go in for surgery really do not inform clinical decision-making about that procedure. Imaging is the one that a lot of people note, is imaging, cardiovascular, and for certain surgical conditions. You can kind of group these for purposes of measurement. Some of these have been studied. There was a recent study in 556 health systems using national data. I do not know how many of them are in California. Some are, but it wasn't broken out that way. Two key findings for us to be aware of, and maybe no surprise, that where there is less primary care, and I know some of you are involved very much in primary care, there is more low-value care. Okay, there's that association. And secondly, probably no surprise, areas of more healthcare spending overall have more low-value care, indicating that some of that high spending is low-value care. So I just encourage the OCA board and the staff to look into, as a driver of costs and spending in California, how much of it is low value, and then what might be done to try to mitigate that. Thank you.
Thank you.
Yes, Marielle Reyataza.
Hi, thank you again for, I'm going to just affirm acknowledging what's happened in Los Angeles. I was one of the first responders as well, so it's been chaotic. Something that I would love to point out is that we are once again struggling for respirators. You know, the city and the county are providing respirators, N95s, P100s, but it feels like COVID all over again. We're all trying to just get as much as possible. We have it at the libraries, we're giving it out for free, but you know, the reality is we don't know how long the air and the land is going to be toxic with all of the fires and how extensive they were with the impact of the Santa Ana winds as well. So, you know, I'm hoping that there is added support on things like that, like PPEs and what's to come, you know, with all of the respiratory distress that people are already feeling. So I just want to bring that out there because I'm hearing a lot of requests from our community members that they don't know how to get there. You know, when I know the Red Cross was involved, but when I was going to different evacuation centers, I asked them, okay, well, what's the need at the other center? They're like, I don't know. We don't keep in touch, which seems very wasteful to me. I don't know why that wouldn't be organized or orchestrated, but, you know, that's what it was. You know, but fortunately, I will say that I'm really proud of how LA came together because, you know, we know that government has a lot of bureaucracy. It takes time, but everyone really came together to do their part. So there's still more to be done, but thank you for that. I also want to know regarding just kind of the budget allocations, will we be getting a more in-depth presentation on how those changes occurred, or maybe even like some visuals, some graphics? That would be really helpful to understand how the allocations have changed. You know, I'd gotten word that CDPH had cut about $100 million from the only LGBTQ plus mental health youth programming. I still have to follow up on that, but I would love to know what's, you know, if we're so invested in behavioral health, I want to know how this was decided because there wasn't any explanation given. And so I know I have a lot of folks who are wondering what happened with that. And then the last thing that I'll just comment, and, you know, thank you, Stephen, for bringing this up, is, yeah, there's studies saying that, you know, if you've got a lot of specialists that are in this specific region, guess what? You're going to see a lot of procedures that those specialists do. That's not necessarily, you know, like, do they need it? I don't know. You know, that's a big question, but I'll just leave that there, that there are studies that say that. So that's it. Thank you.
Thanks very much, and appreciate the information that Dr. Shortell brought and you're lifting up as well. In terms of the budget, you know, certainly we wouldn't be commenting on another department's budget. As you know, there's about to be a very thorough, lengthy budget process with subcommittee hearings and lots of opportunity to engage, and appreciate the interest.
Adam Daugherty.
Yeah, thank you. So I think, you know, in regard to the national health expenditures, I think we're continuing to see a lot of the fallout of the pandemic, delays in care, delays in access, complicated comorbidities, late diagnoses. And I think, you know, a lot of these subcategory increases are a direct result of that. Anecdotally, as your committee's ER doctor here, I can tell you that people are sicker. And, the continued erosion of, specialty access, whether it's in public or private networks, results in that. So, encouraged by the budget and the implementation of ultimately the MCO effort and potential expansion on that front to specialty access. Obviously, concerning on the federal front, whether it's threats to our Medicaid program or continued erosion of Medicare access through reduced reimbursement rates on the primary care side, we're going to continue to see these cost increases because patients can't see. Plenty of physicians now are not taking Medicare patients anymore. So they show up at my door in the ER and I have to admit them to the hospital. So, competing factors there that we need to be intimately aware of. I don't know what the Office of Government Efficiency means or what's going to happen on that front. Of course, it's concerning, but I think, there are potential opportunities that we in California should be leaders in on that front. Yeah, that's it. Thank you.
Hector Flores, recognizing your hand online.
Thank you very much. Just wanted to again thank Director for the comments on the wildfires. And I work with the LA County Medical Association, and we're actively getting information from other medical societies. The website that Dr. Reddy mentioned, the disaster toolkit, I think is the crash card is really important. We started a kind of consolidating all of that information from Sonoma, Paradise, Franklin fires, and others, particularly focused on physician practices affected as well as physicians affected. And the chat's not available, so I'll read out the website. It's LACMA members, LA County Medical Association, LACMA members.com, COM/physician-toolkit. And it's available to non-physician members. We're really interested in hearing from them. We're starting to see the number of physicians' homes that were affected, but also the practices and their employees who were displaced. Either they had to evacuate, they were directly affected by the fires, or schools closures forced employees to stay home with their children. So we are putting a comprehensive set of resources for all those affected, starting with the medical practices. Our goal is to really reopen those practices. The second piece related to the cost issue, following up on Dr. Shortell's comment, is that we're also seeing a phenomena with physicians who are employed. And we've seen the trend the last 20 years. More physicians are stepping out of residency training or fellowships into employed positions. And often they're being incentivized with RVU style compensation, which inherently is volume driven. And we're starting to see some early evidence of impact on low value care. There's a tendency to just start triaging patients out to the specialist offices, or just letting patients naturally flow to emergency rooms, as Dr. Daugherty mentioned. As well as the physician practice not spending enough time with the patients and really just kind of shuttling them through. So that's another area we need to really track and trend and look at the early studies that point to physician employment, which nothing wrong with it. It gives the physician the security of an employed position, don't have to hassle with running a practice. Unfortunately, the incentives are to motivate them to produce volume related services. So thank you.
Thank you. Yes, Parker Duncan Diaz.
I'm essentially going to add on to Hector's comment about low value primary care. Of course, you touched a nerve with that. It's all part of the same bigger problem, and Hector touched on it. It's you kind of get what you pay for. And there's two comments I'm going to extend on Hector's, that a lot of us who are in medical education, I'm in the world of training both family doctors for primary care and family nurse practitioners. It's a bit of that, hey, I went to school and walked uphill in snow every day for five miles. It's a bit of that phenomenon, I realize, but I've never seen it so stark since COVID. Our summary statement is they don't make them like they used to. And what we are getting are people, are graduates who are woefully underprepared to be tackling how complex primary care has become. And what that means is when you don't know what you're doing, you order more stuff unnecessarily and you drive up costs. And I think that's one of the huge recent spike in this. And there's differences from my pride as a family doc between family docs and nurse practitioners, but it's along the same range. I have excellent nurse practitioners, but also when I have a primary care clinician who has been trained for 1 to 2 years versus a physician for 3 to 4, and a 6-month to 1-year residency versus a 3 to 4 year residency, there's just an inherent difference in comfort and clinical exposure. And those who are less trained make more cautious decisions that basically increase healthcare costs. So all of those factors are playing into this that there isn't an easy answer for, but it's a huge area of attention because primary care done right, we know, is what controls and drives down costs. But if you don't put the energy in, we're going to end up with a bunch of unnecessary spending.
Thank you. Carolyn Nava?
Just an additional comment regarding the fires and resources that are available. Coming from Butte County and having lived through, y'all all know, the major fires between Paradise and Park Fire and Camp Fire, and the list is endless. There is a network of centers for independent living. As people are recovering, you will find many with new disabilities coming out of this. Serious respiratory challenges, serious illnesses coming from burns, other things related to the fire. So please reach out if you're wanting to know what is close to whatever neighborhood you're servicing. You can go to CalSilc, that's CalSilc.ca.gov. And you will see a listing of all of the centers down in the fire region, as well as centers that are supporting that area from afar. We have actually up in Butte County also been asked to deliver resources. So you're looking at things like, you know, someone who was fire affected may have lost, for example, a motorized wheelchair that they obtained through the Medicaid Medi-Cal system. When you get connected to that Center for Independent Living network, there are centers who can replace those chairs for free. That's really critical. Replacing medical equipment for free to the individual. So please reach out. Reach out to me if you're having trouble connecting with those networks. We're all connected throughout the state and happy to give whatever support we can.
Thank you. All right, with that, just checking if we can begin invitation to public comment. Okay, so I just have something to share at the start of these repeated public comment periods. We'll now be recognizing members of the public for comment on this most recent agenda item. Please reserve comments on other items for the general comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium, and those attending virtually who want to comment should click the raise hand button. During the public comment period, you'll be unmuted when it is your turn. We also invite you to provide written comment at oca@hchi.ca.gov. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the Healthcare Affordability Advisory Committee is committed to communication and transparency, members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future agenda. I'll start with individuals in the room. Please go ahead.
Beth Capel for Health Access California. A couple of comments. I mean, first of all, the reason that we're all here today is because of the very high costs and high prices for commercial health insurance, particularly here in California as well as across the country. We certainly recognize that the COVID years were unusual, but many years of very high costs predated that. The effort that has become this work dates back 5 to 10 years. It didn't start in the midst of the pandemic. So we take seriously the very substantial increase in private health insurance costs that we are seeing, and especially in the context of the cost targets that are already in place for 2025 and the years beyond. Secondly, with respect to the discussion around low-value care and primary care, part of the reason that the law on OCA includes benchmarks on primary care was because of a recognition that a well-functioning health system is anchored on primary care for exactly the reasons that were discussed here. Finally, with respect to low-value care, the point of the targets is to encourage health systems to manage better. Getting rid of low-value care will be added to our very long list of things that well-functioning hospital and health systems could do, and physician organizations, to reduce healthcare costs while still improving outcomes. Thank you.
Thank you. All right, checking online for hands. I don't see any at this time, and no other members of the public in the room are at the podium, so that concludes this first public comment.
Thank you very much, Karen. And can we just go back to the roll call? I think we had Tam Ma and David Joyner and Carolyn Nava all join us. Welcome.
Yes, thank you. Indeed, and Carmen Comsty as well, and Eliza Arajon online. Have I missed anyone else who joined us after?
We appreciate so many of you are here on this Tuesday after a 3-day weekend. Thank you. And now happy to turn it over to Margareta Brandt and Andrew Farrer to talk about an update on our data submission guide and regulations.
Good morning, members of the advisory committee. Again, Margareta Brandt, I'm Assistant Deputy Director for Health System Performance here at OCA. And so in the next few slides, I'll recap our approach to collecting alternative payment model data and primary care spending data, which is now included in the Total Health Care Expenditures Data Submission Guide 2.0 that has been released for public comment. And then I'll turn it over to Andrew to review key dates in our timeline. So this slide shares a recap of our approach to collecting alternative payment model data. So as we discussed in October, OCA is proposing to collect alternative payment model data using the expanded framework, which is HCI's detailed non-claims data collection framework. And the expanded framework categories crosswalk to the Healthcare Payment Learning and Action Network, or HCP LAN categories. And OCA is tracking alternative payment models that count to our APM adoption goals that are defined by HCP LAN categories 3 and 4. So OCA is proposing to collect alternative payment model data using the following approach. So I'll just walk through some of these in a bit more detail. So we'll collect payment data for APM arrangements linked to quality and those not linked to quality separately at the market category level and product type level, since payments must be linked to quality to count towards the adoption goals. And OCA is collecting APM membership data by market category and product type at the payer level, since the APM adoption goals are tracked by the percent of members attributed to HCP LAN category 3 and 4 arrangements. And we'll collect APM spending data as per member per month and as percent of total medical expense at the expanded framework subcategory level. And here wanted just to share a bit more detail about that. So the total medical expense and member months for members are to be reported in the payment subcategory that's furthest along the continuum of provider, clinical, and financial risk. So, for example, if a health plan pays a care management fee on behalf of a member who is also under a professional capitation arrangement, then all the claims and the non-claims payments and the member cost share will be reported within the professional capitation arrangement row. And this data collection is consistent to how HCP LAN collects APM adoption data, which allows OCA to compare California performance with national APM adoption levels and also potentially other states as well. And then on the next slide, we'll turn to summarize our approach to primary care data collection, primary care spending data collection. So as a reminder, OCA is proposing to collect claims and non-claims primary care spending data by market category and product type at the payer level to track progress towards the annual improvement benchmark and the 2034 primary care investment benchmark. And if we could move to the next slide. Thank you. So here for primary care, claims and non-claims primary care spending will be collected based on the methodology developed by OCA with input from the investment and payment work group and of course the advisory committee and the board. And for claims-based primary care spending, OCA has defined a primary care code set that includes provider taxonomies, places of service, and services that must be present on a claim for them to count towards primary care spending. And then for non-claims primary care spending, data submitters, payers must follow the methodology for allocating a portion of non-claims payments to primary care for each expanded framework subcategory. So for example, we have a methodology specific to each subcategory, so data submitters would follow that methodology for how to allocate a portion of professional capitation to primary care. And lastly, spending for behavioral health care provided in a primary care setting. So some behavioral health services like screenings and assessments provided in a primary care setting will be collected as part of primary care spending. And now I'll turn it over to Andrew to walk through our timeline for the Data Submission Guide 2.0 and our 2025 data collection.
Thanks very much, Margareta. So Vishal and Margareta briefly mentioned OCA's 2025 data collection timeline just a couple of minutes ago, so I'll just add a bit more color here. So excitedly, we were able to post the draft updates to regulations in the Data Submission Guide on January 8th, earlier this month. Public comments can be shared with OCA at oca@hci.ca.gov up through the end of this month on January 31st. And later this spring, OCA expects to submit the updated regulations and Data Submission Guide 2.0 to the Office of Administrative Law in that April time period. And for anyone interested in reviewing said regulations and draft Data Submission Guide 2.0, those can be found on HCI's website, which is also hyperlinked on this slide. We can move on to the next slide. All right. Just a little bit more context here on the data collection timeline beyond April, which for those of you familiar with this past year is going to be very similar. So required submitters are expected to complete registration through OnPoint's Claims Data Manager in May. Then in June, required submitters have the option to submit test files. This we found to be quite helpful to work out any connectivity issues that may come up. And then during the months of July and August, that's the time period where submitters can prepare and submit the required files based on calendar years 2023 and 2024 spending and enrollment data. Just as was the case this past year, OCA will meet with data submitters to answer any questions and to provide technical assistance if needed. And required submitters are expected to complete their data submission on or before September 1st of 2025. And then towards the fall of this year, OCA will once again meet with submitters to review their data and to preview what they can expect to see in the baseline report. And on that note, OCA's second baseline report will be published on or before June 1st of 2026. Turn it back over to you, Vishal.
Thank you. We'll be looking for any comments or questions or feedback from committee members, but just to make a note about attendance, my apologies, Stephanie Klein, we see that you are present online. She's been in attendance, and Kieran Savage-Sangman has just joined us in the room. Welcome. With that, questions, feedback, comments? Yes, Travis Lakey, please go ahead.
Thanks for the question, Travis. So some of the context is that we're getting existing data from DHCS through the Medi-Cal medical loss ratio MLR filings. So we're able to measure total medical expenditures for MCO plans through DHCS. And then there's separate files where we do attributed provider organization spending. We give instructions on how to attribute spending to physician organizations. So we'd like to get that process right with the commercial and Medicare Advantage plans before we extend that requirement to Medi-Cal MCOs. And then, so that was kind of our first round of data collection. And now under the proposed data collection for 2025, we would require the MCOs to report APM or alternate payment model and primary care files. So they'll get another extension on the TME or total medical expenditure file. But then going into 2026, we'll kind of see where we're at with the commercial and MA provider organization files. And if we're in a good place, we'll extend that requirement to Medi-Cal MCOs.
Is the data you're getting from that other source kind of equitable with the other data you're receiving?
It's essentially the same. Our definition for total healthcare expenditures is claims, non-claim spending, and then the admin costs and profits. So we're getting the equivalent measures from DHCS on those.
Any other questions or comments? Okay, is there anything more on this item from staff? No. Okay, well then we will open it up for public comment for agenda item 3. Again, looking for anyone in the room to step up to the podium or online to raise their hand. Okay, I'm not seeing any members of the public requesting to speak in the room or online, so I think we'll move on to agenda item 4.
So Andrew and I will be presenting this item together, and Andrew will start off and pass it back to me later on in the presentation.
Great, thanks, Vishal. All right. So this is a fairly lengthy section. So I would encourage folks to ask questions as they emerge so we don't wait the better part of 25 or so slides for comment. All right, but we will begin by briefly exploring California's hospital landscape. So as you can see on the slide here, California has about 440 hospitals. They range from large academic medical centers to community-based hospitals. They're dispersed across urban and rural areas with the highest concentration in metropolitan areas like LA, San Francisco, and San Diego. The hospitals include general, children's, psychiatric, academic medical centers and teaching hospitals, county hospitals, small and rural hospitals, critical access hospitals, and specialty care facilities that provide specialized services, many of which are described on this slide. We can move on to the next slide. And one more. So we'll briefly provide a recap of the board's discussion from the November meeting. And so during that meeting, the board discussed various hospital attributes that may warrant special consideration when establishing a sector and sector target for high-cost hospitals. And those attributes are outlined on this slide. They include critical access hospitals, small hospitals, psychiatric facilities, children's hospitals, teaching and academic medical centers, specialty hospitals, state, county, and long-term stay hospitals. And board members during that discussion suggested that many of these attributes may warrant distinct consideration or even exclusion when defining a hospital sector and establishing sector targets for hospitals. In addition, board members suggested the following: factoring in geography or rurality to any hospital sector target. Since state and county hospitals rely to a lesser extent on commercial payment and in many cases are funded in whole or in part by state and local appropriation, they may not warrant a lower spending target value. Psychiatric hospitals are funded differently by Medicare and thus may warrant distinct treatment. Additional comments included children's hospitals receiving little Medicare revenue and some may have different billing practices. Long-term stay and specialty hospitals are a heterogeneous group and some may warrant distinct treatment or consideration while others may not. Critical access hospitals and small hospitals, depending upon how they are defined, may not warrant lower spending targets. Most teaching hospitals and academic medical centers likely do not warrant distinct treatment. And then finally, because that discussion was largely at a conceptual level, the board requested a review of hospital data by facility attributes and several financial metrics. All right, we can go to the next slide. So just to provide some definitions of facility attributes before we get that data review. So we'll start with critical access hospitals. So CHAs tend to represent a separate provider type within their own Medicare conditions of participation, as well as a separate payment method. And so those COPs for critical access hospitals can be found in the Code of Federal Regulations. Small hospitals, for the purposes of forthcoming slides, were defined as those with less than 100 licensed beds. Psychiatric hospitals have a self-reported designation in HCI's Hospital Annual Financial Disclosure Reports, and these hospitals provide a preponderance of psychiatric services. Psychiatric health facilities are small county-operated hospitals licensed by the Department of Healthcare Services. They provide 24-hour inpatient care for people with mental health disorders or other persons described in the Welfare and Institutions Code. Children's hospitals are another self-reported designation in the HCI Hospital Annual Financial Disclosure Reports. So we note that there could be hospitals that specialize in or provide pediatric care that do not necessarily identify or self-identify as a children's hospital. And then finally, rounding out this slide's list, teaching hospitals are identified using the American Medical Association's Graduate Medical Education Directory. A couple more definitions on the next slide. All right, so specialty hospitals. So OCA didn't identify a statutory definition of what constitutes a specialty hospital, but examples of the type of care provided at specialty hospitals can include rehabilitation, cancer treatment, heart surgery, addiction recovery, respiratory care, neurological services, long-term care, orthopedic surgery, and mental health care. Designated public hospitals or public hospitals are defined in Welfare and Institutions Code listed on the slide. There may be other county or predominantly county-run hospitals that are not necessarily included in that definition, however. State hospitals provide mental and behavioral health services to patients referred by a county court, a prison, or a parole board, again, as defined in Welfare and Institutions Code. Long-term stay facilities, for the purposes of our operationalization in the forthcoming slides, were defined as facilities that had average lengths of stay greater than 20 days. And then finally, fully integrated delivery system hospitals are those that are part of a fully integrated delivery system as defined in Health and Safety Code. As OCA noted in December, many of these facilities and their attributes may merit consideration, are not always easily defined nor clearly defined or referenced in statute. So with that, we can open it up to the advisory committee to see if folks have any input on whether any of these attributes would merit special consideration or exemption from a high cost sector target or high cost sector target value.
Yes, recognizing Sarah Sorokin has joined us. Welcome. And she has a comment or question.
And I apologize for being late and missing the whole presentation. I had some tire problems. So these questions, maybe they've already been answered, and some of this reflects my learning curve with this. But so what would be the rationale for a hospital to merit an exemption from a high cost sector definition? So that's one question. And then, because truly that's something I don't understand, something I'm trying to learn more about. And then also, this may be in a future slide. I just wrote some notes when I looked at the slides, so you can address this later. But I'm wondering about Kaiser hospitals, like the fully integrated hospital systems. Yeah, I think this is in a future slide, so I will wait on that. But I guess that's my main question, like what would merit exemption?
Thanks, Sarah. All hospitals are subject to the statewide target of 3.5% this year, and then it's going to ratchet down over time. So the kind of the question before the board and advisory committee and the public is we're going to do some discussion at the board level about defining a sector based on the discussion that occurred in December. Board members will be going over some options, and there was one option about defining all hospitals as a sector. So once kind of the board makes a decision on that, kind of then the question is sector target values. Kind of the goal of a sector target is to go further to have a lower target than the 3%, and focusing on those high cost hospitals. So it's more of an open question to the advisory committee. Is there something we need to think about as we're proposing options to the board?
And just in terms of order of hands, it'll be Joan Allen and then Andrew C. And then I see Stephen Shortell's hand. Joan?
So several thoughts, and so I'm going to try to organize this a little bit. When I look at this, one of the things that I look at is which hospitals do we need to capture in order to move the needle, to really start with what I would call sort of our biggest worst. And so recognizing that as we are tackling that biggest worst, it may well make sense to do some exceptions. And as we get into the slides further on about how those exceptions change the landscape, it really does become clear that we probably do need to make some distinctions between types of hospitals, and hospitals like critical access that are paid on such a fundamentally different basis, or state hospitals. So definitely feel like there's some attributes here that really do make sense. Once we get into non-categorical attributes, things like where do we cut for small hospital, or where do we cut for average length of stay, that gets dicier for me, because that's something that changes. That's not a fundamental characteristic of a hospital. So that's something that changes from year to year. And so how long would we be locking a hospital into being on one side of the exemption or the other gets tricky, and we need to think about that. Also, there are some of these that are where there are multiple ways to define them. For example, looking at the hospital utilization data, there are so many different fields for average length of stay that it would be very helpful in order to do this analysis if we could get just a little bit more data on, when you say average length of stay, which field are we using? Is it just the acute? Is it the total? Is it the calendar year or the program year? I think there are 20 different average length of stay columns. And then also that goes to the small hospital definition. So just getting the spreadsheet would be very helpful. And also that goes a little bit to the psychiatric hospital. I was a little surprised to see the definition being the one out of the hospital annual financial as opposed to the license category. Because we have license categories for 2 different types of psychiatric hospitals. And there's a pretty good mapping between the ones that are identified in the hospital annual financial as opposed to the 1250.2s and the 1250Bs, the psychiatric health facilities and the acute psychiatric hospital. It's not perfect, but it's pretty good. And so those are all sort of the things that are swirling through my head. On this slide, as compared to one of the earlier slides, specifying county and state hospitals as opposed to designated public, I do appreciate. I would strongly encourage we not use designated public hospital because of how much broader that definition is. Feel like capturing the UCs in an exemption would need to be a much longer conversation. But yeah, those are some of the things that come to mind for me. But really, a lot of the request is, can we get the spreadsheet?
Thank you, Joan. Next we have Andrew. After that, it'll be Stephen, and then Eliza online.
Yeah, so I guess I'm just thinking about sector in the context of the whole, right? So we're trying to get overall spending down, to the levels that we specify. So I guess I don't know if we have a fully fleshed out plan of here's this sector, here's that sector, but when we put Humpty Dumpty back together again, it has to come back, right? Or some version of that. The other thing on the hospitals, I do think if you're thinking about really small ones or ones where you just have a lot of volume volatility, you could probably think about, maybe, I hate the word exemption, right? Because when you look at the way we're measuring this, first off, you have a baseline. So let's just say you're academic. Okay, fine, you have higher costs, but it's in your baseline, right? We're talking about the trend. We're talking about the cost growth. So, it's in your baseline. We're talking about the growth. Why would the growth be differential for one hospital versus another? And I think the only thing that goes in my mind is if you're a small hospital that just has a lot of volatility, then, then becomes a credibility issue at that point. But larger hospitals, I struggle. And then I'm back to how do we put all the sectors back together so you end up with a coherent, to the consumer, it's this cost growth target, right? Because if you start dispensing, okay, well, you get an exemption, you get an exemption, you get an exemption, okay, all the players kind of add up to the whole. And maybe, Kaiser is in a different spot, right? Because we manage the total cost of care. So it's a very different paradigm. But once we start talking about sectors, we have to think about how do you manage the whole and how do you create incentives for the whole?
Thanks, Andrew. I just want to remind folks that any entity will be, every entity will be subject to the statewide cost growth target unless and until there's a more specific sector target. So if the board chooses to set a hospital sector target on some hospitals, those that aren't subject to that won't be exempt from any target. They'll still, the 3.5 will still apply to them.
Stephen Shortell.
Yeah, just a couple of quick observations. The list here, they're not mutually exclusive, okay? And so I think we all recognize that. And one example, if a hospital is part of an integrated health system, that particular category, that will include small psychiatric, a bunch of others as well. So one example would be not to create integrated health systems as a separate category, keep it, whatever the hospital is, and then just have a marker that says, is it part of an integrated system or not, and see what difference that makes, would be one way to handle that. And the other observation, I think, building on Joan's comments, is have you already got some idea of the spreadsheet and the data you're going to present to the board to flesh this out and populate it so they can kind of see? And if so, can you share that with us at this time, just in a preliminary way?
Oh, yeah, Andrew will be going over data.
Later on.
And it'll show some of these attributes.
Eliza Arjoyan, and after that, we'll hear from David Joyner and then Tan Ma.
Thank you. The observation I'd like to just put out there for consideration is as I look at this list, quite a few of these, including number 4, number 5, and number 1, in terms of attributes, are some of the costliest hospital systems that we work with on the health plan side. So as we're looking at sort of what we define as attributes to be included or excluded, I would offer, again, looking at the data and making sure we're not unfairly or unnecessarily excluding hospitals that are materially impacting cost of care. Thank you.
Thank you. David Joyner.
Yeah, thank you for this. My comment's a little bit similar to Steve's comment. So I can think of hospitals that would be classified in more than one of these categories. So for example, Oakland Children's is a children's hospital. Also, it's part of an academic medical center. Same is true of Lucille Packard in Palo Alto. So how are you thinking about, if the idea here is to separate these hospitals and potentially have different consideration or different targets or different treatment, how are you thinking about those hospitals that would be classified in more than one of these categories?
Yeah, it's a great question, and the forthcoming slides will show just the extent of overlap across a number of these facilities. I think to some extent, the HCI financial disclosure data will help prune some of the hospitals for which simply we won't have the requisite underlying data to compute a lot of the metrics needed to understand some of the trends that Andrew was speaking to. So I think it's really just to inform a conversation, but I don't think we have sort of reified preferences or ideas on exactly how you would stratify across one category or just omit entirely a given set of hospitals. So it's really just trying to give a flavor and being responsive to the board on understanding some of the heterogeneity across the hospital landscape. But as you'll see in forthcoming slides, there really isn't a neat and tidy way of simply sectioning off or siphoning off some hospitals versus others along some of these both continuous and discrete variables that are noted on the slide.
Thank you. Tan Ma, and then we'll hear from Carmen Comsty.
We all share the same kind of Medi-Cal financing mechanisms, and particularly the unique role that we play in self-financing for in the Medi-Cal program, and have the similar challenges when it comes to. I think. Yeah, thanks. Yeah, and just a role in self-financing in the Medi-Cal program, and the and considering how like the metrics and analysis, what metrics and analysis are needed to consider how these self-finance payments are reported and how it affects our performance. And then I think, I'd like to spend some time digging into the definition of teaching hospitals as well. And I think in the materials that you use teaching hospitals and academic medical centers kind of interchangeably. And I think like kind of all academic health centers are teaching hospitals, but not all teaching hospitals are academic health centers. So I just wanted to leave that point there as well.
Thank you. Carmen Comsty.
Thanks for this. I think, when I'm looking at this list of potential, I don't even know what adjustments or different exemptions or special consideration for the targets, I think there's a little bit of, some of these definitions are capturing too many, and we don't want, I think also with Children's Hospital in Oakland, that's affiliated with UC. Would that be put into an exemption? I think there's a lot of considerations to be made in terms of the specific hospitals that we're looking at. I do worry about the length of stay as an exemption, because what point in time, other than what Joan pointed out, which length of stay, column are we looking at? But when in time are we looking at length of stay, and what, I know that the proposal is looking at 20 days. I think that's what it said. I think we have to think about if that's going to cause different types of reactions to try to increase or decrease the length of stay to get in or out of an exemption. I guess, overall, the question is, what are we actually concerned about? We want to make sure that hospitals that are putting funds towards things towards care that is necessary, have the ability to spend those dollars. I get worried about us not having workforce stability standards yet, and what that means in terms of whether or not we're hospitals to support increased types of staffing, and will that affect, particularly with various types of hospitals, what does that mean in terms of an exemption? If we're looking at specific hospitals, even meeting the other benchmarks that we have within the spending targets. So I think this may be oversimplifying things, or capturing too many hospitals potentially in an exemption. But I think first things first, I agree with Joan. Let's get a list of the hospitals that we think are in these definitions, so that we have a better sense of what this actually means, rather than kind of broad swath using various definitions that exist in the law and trying to shove them into the spending targets, the growth targets.
Thank you. In order of hands, we have Travis Lakey next, then Adam Doherty, then Andrew C.
So in the OAK analysis, what data attributes and what data and hospital attributes are missing from the analysis? Because I know there's a wide set you're having to kind of narrow it down to.
Yeah, we'll be covering various metrics, some key hospital spending measures. So we could return to that question when we cover those slides.
Adam?
I appreciate the comments on even just the definition of what a teaching hospital is. That's continuing to evolve. What we can call non-UC teaching centers that are bearing an increasing number of trainees, just given the fact that we need, to keep up with workforce needs in the state. So, considering what that means, particularly over the next decade. And then, looking specifically at number 6, even within what is defined as a specialty hospital, that in of itself is incredibly heterogeneous. One facility may provide a number of services next to another facility that doesn't, which creates disproportionate cost centers, one or the other, whether it's a receiving center within the same health system or, even between, looking at specific payer mix in those specialty hospitals where we would probably need to charge more on commercial plans to keep the lights on if it's a predominantly Medi-Cal population within that facility. So just the definition of a specialty hospital is, I think needs incredibly more specific, subcategories.
Thank you, Andrew C.
Yeah, and I guess maybe I missed the meeting, but do we have the actual definition of the metric that we're actually measuring them by, right? Because at the end of the day, you have to look at, what is the exemption in connection with the metric itself? Because if you're looking at something that's already case mix adjusted, and then you've grandfathered in their current cost structure, right? And back to hospitals aren't mutually exclusive. So there's not a clean way to say all teaching or all this is exempt. But, if you look at the metric, what are we doing? If we're just looking at an increase in the trend and you're adjusting for case mix, other than small hospitals where you're going to have a lot of volatility, I really struggle. So that's one man's opinion.
Yeah, thanks, Andrew. That's probably just a preview. We'll be covering inpatient net patient revenue per CMAD. We'll look at, we'll break that number out by commercial, average annual growth in inpatient NPR per CMAD, average operating margin. We'll also look at this way to look at relative price, comparing commercial to Medicare. And then going back to what Andrew said, or what Adam said earlier, regarding specialty hospitals, there's not like a clean definition we could just point to and capture every hospital that's a specialty hospital. In the HCI financials, hospitals self-attest to being a specialty hospital, so we'll kind of show data related to that shortly.
Marielle Royataz, I see your hand.
Yeah, thank you. I also just wanted to add to Adam's comment on medical training. There's a huge, we've known for a long time, right? We don't have enough providers. That's something that's been echoed in several health professions, allied health, including medicine. there are lots of talks about, getting more folks into medical school, getting more medical schools, but the truth is we don't have enough residency positions to actually complete and usher even U.S. Medical school graduates into a training program. We don't have enough. And we have more and more foreign graduates who are coming in, and that's fine, no problem there. We also have a lot of American students who go and seek medical school and training in, let's say, the Caribbean. Lots of variation there. But the truth is, right, if the bottleneck is always going to be, having some kind of residency training and there just aren't enough spots, it doesn't, we can increase the total number of students, of schools, but this is going to bottleneck and it's going to keep happening until that's something that we can actually address. So I just want to point that out because it's something that has been going on for decades and it's only going to get worse.
Thank you.
So I'll be covering the next slide and then I'll turn it back over to Andrew. Just to start at the beginning here, we want to level set on the process for implementing sector targets. In essence, establishing sector targets, it's a two-step process. First, the board needs to define sectors, which are then codified in regulation, and we'll be going over that, more details on that later. Then the board can establish sector target values for the sectors. The process for establishing sector targets mirrors the process we used last year for establishing the statewide target. So the office will need to propose target values on or before March 1st. We'll have to do that before our February board meeting in order to meet that statutory deadline. So a 45-day public comment period will follow the February board meeting. It'll essentially start the day of the board meeting. And the board will have until June to approve target values should they just decide to continue on the path for sector targets. The target value would be for calendar year 2026. Moving on to kind of the last part of this slide. So in December, the board focused its discussion on step one, which is defining sectors. Many of the slides that we're going to cover with you today is what we showed the board in December. And then we also presented some options for how to define a sector. So today's discussion will mainly focus on how to define a sector. And some options we'll present later on will address how to define and establish potential sectors. We'll return in later meetings with options for both the board and, the board would be next month. They'd get some options for sector target values. And then we would, in the March advisory committee meeting, we would also get your feedback on options for sector target values. And now I'm going to turn it back over to Andrew.
Thanks, Vishal. You can go on to the next slide. All right, great. So before we get into descriptive statistics, we first just wanted to provide a brief overview of HCI's hospital reporting requirements, and this will touch on some of the comments from David and others on sort of which hospitals are included or excluded potentially. So on an annual basis, individual hospitals and hospital systems report detailed facility level data to HCI, and that includes services capacity, inpatient and outpatient utilization, patient seen, revenues and expenses by type and payer, as well as balance sheets and income statements. Importantly though, not all hospitals are required to submit all hospital annual financial disclosure report data, either because of statutory exemptions or because a reporting modification has been granted. And so the slide here will outline those hospitals. So the first is the Kaiser Hospital. So by law, Kaiser is allowed to submit consolidated financial statements for their northern and southern regions and limited financial and utilization data for their individual hospitals. Long-term care emphasis hospitals, there are 4 in the state of California, and they primarily provide long-term care. So while each of those hospitals does submit full disclosure report data to HCI, HCI generally advises against their inclusion because their data may not be comparable. Psychiatric health facilities. These are county-operated facilities that are permitted to submit limited data because of their small size, idiosyncratic patient mix, and the type of care provided. Penultimately, here we have Shriners hospitals who are permitted to submit limited data because of their charitable mission and because patients are not billed for services. And then finally, state-operated hospitals are permitted to submit limited data because of, again, their idiosyncratic patient mix and type of care provided. Okay, we can move on to the next slide here. So based on discussions with the board in November, OCA aimed to provide an overview of descriptive statistics ranking the top 30 hospitals across 5 financial metrics, averaged from a 5-year time series beginning in 2018 through 2022. For those of you that were in attendance in December, CJ made frequent mention of the fact that these are a select and illustrative set of metrics, so I will reiterate that point. So they aren't meant to convey a methodology or recommendation on how to define a hospital sector or establish sector targets. We did, however, aim to identify measures that address overall cost growth, profitability, and price. And so to evaluate cost at the hospital level, OCA sorted hospitals based on their average inpatient net patient revenue per case mix adjusted discharge, as well as the average commercial inpatient NPR per CMAD. So there was quite a bit of feedback that as part of that first measure, you're pooling an awful lot of different payers. And so if you could sort of begin to dig underneath the hood a little bit and dig into commercial, that would have been edifying. And so we'll aim to do that today. Next, to evaluate cost growth at hospital level, OCA sorted hospitals based on their average annual growth per inpatient NPR per CMAD. Then for profitability at the hospital level, OCA sorted hospitals based on their average operating margin during that 5-year period. And then finally, as Vishal just noted, to evaluate relative price at the hospital level, OCA sorted hospitals based on their average commercial to Medicare payment to cost ratios. And so the first section of our slides today will highlight the top 30 hospitals for each metric with minimal exclusions. Again, circling back to that differential set of reporting requirements, not all hospitals provide the requisite information to enable reporting across all financial metrics in all years. And similarly, due to either hospital closures or other circumstances, not all hospitals will appear in all 5 years. Okay, the second section will include the top 30 hospitals for each financial metric with the following hospitals omitted. Critical access hospitals, small hospitals which are defined as having less than 100 licensed beds, psychiatric health facilities, children's hospitals, state hospitals, Kaiser hospitals, and long-term stay hospitals, again, which we've discretized as having an average length of stay of greater than 20 days. All right, on to some definitions, and I'll again extend the invitation. If folks have questions as we mosey on through these slides, please don't hesitate. Oh, please.
You already have one from Andrew C.
Sorry, just quick question. We probably may not have the data, right? Because you're looking at just inpatient metrics. We're kind of missing a lot on the outpatient, right? ED, outpatient surgery, ambulatory surgery centers. I mean, it's a lot of volume. So maybe that's to come.
Yeah, more to come on that one. I believe either the October or the November meeting, we did talk about OCA's provisional measurement approach for hospital spending. We had convened a hospital spending measurement work group, kind of a cross section of hospitals. So the data we're going to show you today is going to cover the inpatient component. On the outpatient component, because the HCI financials don't have an easy way to get at the case weights for outpatient services, in terms of the data that the hospitals report to HCI, we have utilization counts of outpatient visits and so on, but we can't apply a case mix weight in the same way we do on the inpatient side. But we're working on that. We're looking into some options to enhance the HCI financials. So it won't be part of the data that's presented today. But as far as measuring a hospital against the target, the ultimate measurement approach would be inclusive of both inpatient and outpatient revenue.
Okay, so the staff is planning on blending the two, right? Similar to what Maryland does. HSCRC in Maryland does kind of this equivalent case mix adjusted discharge.
Yeah, that's actually what we had presented on, and we did get some feedback from the board, and they had kind of given us some feedback about how do we kind of do better than the ECMADS approach. So we're actively exploring that.
David Joyner.
I have a question about the Kaiser situation, because I'm seeing potentially a conflict between an existing exclusion for sharing detailed information and the OCA legislation that I think mandates submission of data. And how, which of these laws takes priority? Because I guess my concern is Kaiser's an extremely large player in California, and to have a player the size of Kaiser not be included fully or included at a level of detail that's less than other hospitals strikes me as very inequitable and not really tackling the problem the way we should. So can you talk about how to navigate this and which state law takes precedence?
Yeah, thank you, David. It's a good question. So Kaiser is not exempt from the statewide target. It applies to them, but they have a statutory definition in the OCA enabling statute, which defines them as a fully integrated delivery system. So we're not going to look at Kaiser Health Plan, Kaiser Permanente Medical Group, and Kaiser Hospitals as individual entities. They're going to be measured as a system against the target. So as part of this exercise, they would not be part of the data analysis or sector target values. The board would need to define Kaiser as a sector, and then if they want to set a different target for Kaiser, they can do so. But as part of this discussion, the statewide target applies to them.
Yeah, I understood that this wasn't about an exemption. Where I was going is that I think part of the reason you're collecting all this information is you want to have insights as to why certain hospitals are higher cost than others, right? And you were saying that in the case of Kaiser, you wouldn't have that kind of insight because the data wouldn't be granular.
Oh, yeah.
And so I was saying, you've got a pre-existing exclusion. Now you have this new law that OCA was created under, which I think has within it embedded requirements for the health system providers and plans to submit information to you. And I was asking kind of which of these laws takes precedence? Because you might say, well, the existing exemption doesn't apply because it's been overridden by the new OCA law that would require more granular information to be submitted. So I'm worried that we'll have a massive sector. You're going to have like very little insight because it's all blended together. And that's going to be a problem in terms of as you try to manage against these targets to describe which hospitals are not meeting them and what the reasons are, et cetera.
Yeah, I think I understand your question now. So for OCA's purposes, Kaiser would be measured as a system, but there's other state law about reporting of HCI hospital financial data. So Andrew, did you want to speak to kind of the change where they historically they did report as a system, but now they're going to be reporting by individual facility?
Yeah, thanks, Vishal. So as part of that 5-year time series we have from 2018 to 2022, there is a sort of a change starting in 2021 where we do begin to get the more granular financial and utilization details to be able to compute some of these metrics, but it is only 2 out of the 5 years based on that current 5-year snapshot we're using.
Okay, so for more recent information, there will be the granularity that's available for the non-Kaiser system.
From 2021 onward, yes.
Okay, great. That's much better. Thank you.
Okay, Andrew, back to you, I think. This Andrew.
Thanks. Okay, so just to help provide some color on a lot of these concepts and terms, we'll just provide brief definitions here of each of the corresponding metrics, starting with inpatient NPR per case mix adjusted discharge, or CMAD. And so that's the amount of money a hospital generates for inpatient services, excluding charity care, bad debt, and contractual allowances. And it's adjusted by the number of hospitalizations to account for inpatient volume as well as the intensity of inpatient services. Next, so this wasn't presented in December, but based on, as I noted, feedback from a number of different channels, we did want to sort of break out that pooled measure with a little bit more detail and providing insight into the commercial payers. So this is commercial inpatient NPR per CMAD. And so it's very similar to that first metric. It's the amount of money a hospital generates for inpatient services, but it's solely focused on what are known rather inartfully as other third-party payers. And so these data for commercial patients as well as other government programs are reported as that other third-party category in the HCI hospital annual financial disclosures. Having consulted with some of our hospital data collection SMEs within HCI, commercial payer or patients tend to comprise about 80% of that other third-party category, just to give some context there. Next, we have a growth metric. So this is annual growth in inpatient NPR per CMAD. And so this is just simply going to be the average annual change in the amount of money a hospital generates per unit of inpatient services, average from 2018 through 2022. Then we have a profitability metric, so operating margin, and this is going to be the net income from operations divided by total operating revenue. And the ratio indicates the percentage of inpatient revenue that remains as income after operating expenses have been deducted. So typically, you would interpret a positive operating margin to denote profitability. And then the last metric here is that relative price metric Vishal noted. So it's the commercial to Medicare payment to cost ratio. So it's the Medicare and commercial net patient revenue divided by the Medicare and commercial costs. And so the ratio compares that amount that a commercial payer will pay for a medical service compared to what Medicare would pay for that service. And it shows generally how much more or less that commercial payer pays relative to Medicare's rate of service. All right. Any questions before we move into, yes?
This is Mariel Reataza.
Thank you for explaining that. You know, earlier today, Elizabeth had mentioned that, you know, we've seen a rise in administrative costs and burden. I'm wondering how that will be calculated, or if it will be calculated in these metrics. Again, just administrative part of the costs.
So the net patient revenue measure typically covers for healthcare services delivered. The HCI financials do have other data elements related to administration and profits. We, like the operating margin, would cover the profits part. We didn't focus on administrative expenses in this presentation.
Thanks for explaining that. Is there going to be an effort to disaggregate that kind of data, or at least pull it out? Because we know that, you know, administrative burden is a huge, is an important reason for why healthcare costs so much here. So, you know, I'm hoping that we find a way to actually, you know, collect that data and quantify it and do something with it. Because if it's going to keep rising with more and more bureaucracy, like what's going to happen? What is this eventually going to look like? I just worry that, you know, we get kind of stuck in the weeds and we just add more and more administrative burden. I'm not saying that this is adding necessarily administrative burden, but I really think we've got to look at what's happening there to address these, high costs. And I think if we miss it, we're really failing to address huge, sorry, I'm trying to find the words. You know what I'm saying. So.
Yeah, I think I'd clarify that while the figure that we're presenting is for payments for patient care, embedded within that is the administrative expenses, because that's kind of, you know, the prices that a hospital would charge for commercial, and then, other payers also, the payments would reflect the administrative expenses as well. So it's reflected in the data. We just don't disaggregate it that way. But the purpose of the spending target, kind of stepping back, is we're not necessarily kind of digging into every single line item, but we set an overall target, and then entities could meet it in various ways. They could reduce their administrative expenses. They could do more care coordination or reduce other wasteful spending. So it'll be up to the healthcare entity to kind of see which tool they want to use to meet the target.
Thank you. I feel like this conversation is not over, and I'd like to address this further. If you know, I really, really think that we should look into this.
Thank you. We can take that back.
Thank you.
Thank you. The next time was Ken Stewart, and then Sarah Sorokin, and then Joan Allen.
Yeah, thank you. My question is on the determination of inpatient revenues. Are we coming from the billed amounts and the the hospital charges that are submitted to HCI, or with Medicare, everything comes right down to what they allow? And in the private sector, we go right from billed to allowed. Bill charges really don't mean anything to us.
Yeah, these are not gross numbers. We're presenting the net amount, so it's after all the contractual deductions and all of that. So
Okay.
it's the allowed amounts.
All right, thanks.
Sarah Sorokin.
I just wanted to second what Marielle was mentioning, and I don't know if it's in the statute to be able to disaggregate admin data or profit data, but given that at least maybe general opinion is that, and someone could correct me if this isn't accurate, but general opinion is admin costs are part of what, and profits are part of what separate our healthcare costs from other industrialized nations' healthcare costs, that it would actually be very worthwhile to look at that data disaggregated to have a clear picture of how that is playing a role in increased costs.
Thank you, Sarah. Joan Allen, and then Mariel. And Carmen
Yeah.
Comsty and Adam Doherty.
Along those same lines, would love to, as this matures, get to a place where we are investigating not only how much our hospitals spending and taking in, but how are they spending that money, and whether it is administrative burden, administrative overhead, profit, spending on frontline workers and care. Feel like there really is more under the hood here. Recognize that that's not going to be a year one, but that as we mature, it would be very good to start tailoring to reward and encourage and incentivize the type of spending that we want, and discourage some of that administrative cost and profit where we know that costs are being driven up, like Sarah said.
Mariel Taza.
Thank you. I appreciate the added comments on administrative burden and the cost that it adds to our healthcare system and utilization. A very tangible example, right, is the added burden of electronic health records and all of the documentation that's involved. I mean, that gets in the way of patient care and patient outcomes because there's so much time spent documenting. And I get it, documenting is important. We play a lot of defensive medicine, unfortunately, because that's how our system is rigged. But again, right, the admin doesn't just extend to like insurance and payers. We're also talking about all of the admin that burdens providers. It's a lot and it's overwhelming. And as we see health systems focus on, return on investment more than patient care, right? They are cutting staff from various departments so that, they can meet their revenue desires, whatever. I'm not, a healthcare provider. I'm not a payer in that way, right? So these are real examples and you imagine that extends and amplifies in like various degrees, right? I'm just talking about one example. So there's a lot more to look into that. And I really encourage that we do a deep dive into this. Thank you.
Thank you. Carmen Comsty.
Yeah, I just want to, I don't think it surprised anybody that I would like information on administration and profit and marketing and all these other things. I think in the conversation with respect to, hospital sector targets, I think where the rubber hits the road here for me on that kind of analysis is the operating margin, because it's not clear to me what exactly is, what are we calling operating expenses? You know, we want to make sure that when we're kind of looking at these numbers, we're not just taking the prices as acceptable and given. I know that we're looking at net patient revenue in various aspects, but it's really trying to figure out, you know, how are prices being justified by healthcare providers, by hospitals, and what's going into that, so that, you know, I know that this analysis, we're looking at kind of the overall picture, but I think it's a fundamental question and kind of what we're looking at here. And I think, you know, when we're using various formula where all we're looking at the end is operating margin and various net patient revenue, there's that question of like, what is it? Is it justified? What it is, you know, do we agree with what the outcome is in the calculation of net patient revenue and margin? But I think that might be a way where we can look at it, and I do think OCA should try to figure out how we can look at what's going into these calculations, and what, you know, I think to, you know, I think what we're trying to do is figure out where is there too much cost that is not going into care, and that's why it's important to look at these kind of other things that we know are happening within the healthcare system. And yeah, and it's just hard to look at these numbers and not try to figure out what exactly is going on when we're breaking down the various health facilities here.
Thank you, Adam Doherty.
I appreciate those points. A little bit of a can of worms here. I think we're on opening finally around what are operating expenses, you know, looking at, you know, regulatory requirements, compliance officers, are they all actually adding to patient care, and what have we imposed on our health systems from, you know, a regulatory standpoint? Risk, all our lawyers who are telling us we, you know, involved what we can't do based off, you know, risk profiles. Of course, executive compensation and profit sharing and administrative duplicity, you know, all the individuals in, whether it's quality, whether it's you know, any number of billing or collections, or you know, all those services, you know, finally having the discussion under what is operating expenses to run a facility. It is beholden to this group to you know, not just quantify that, but be able to describe it. And I think we have an opportunity with, you know, a lot of our data collection, you know, mandates here, is that all needs to be a part of finally that conversation. You know, a couple of the other, you know, perspectives. I really like the commercial to Medicare ratio. You know, I think we should add in Medicaid as well to that. It is approaching Medicare levels now. Looking into the future, but I think it would still be useful to think about that given different payer mixes and changes over time, as well as far as the NPR. You know, of course, that's important. Looking at kind of our worst players, I'm less interested in the impact of, you know, the Shasta Medical Center. I'd rather see, you know, more of a total N. You know, looking at the biggest numbers and the biggest impacts in our urban centers, as opposed to the average or the rate. So more of just the N to be able to rank those as well, to see, you know, biggest bang for the buck, essentially.
David Joyner.
I've got a question about the operating margin. If the operating margin is the net income from operations, including inpatient and outpatient services, is that the case? If it is the case, why wouldn't you have some other metrics that relate to outpatient services, like net patient revenue per ED visit or net patient revenue per outpatient surgery? It seems like we've got a lot on inpatient and not enough on outpatient, if you're going to look at the total operating income.
Yeah, the first question, operating margin, is inclusive of both inpatient and outpatient care. So the way the HCI financials come in, there isn't a way. Outpatient encounters are it could be a lab test, it could be an ED visit, it could be an ambulatory, like a outpatient surgery. So those are all three different encounters. And the way we're calculating this inpatient net patient revenue per CMAD, you have to have a denominator, and we can't treat each of those outpatient encounters the same because they require different levels of resource. So there's not, the hospitals today are not reporting case weights for a lab test at an outpatient surgery or an ED visit, so that the data doesn't come in that way. So we're not able to calculate that case mix, an equivalent case mix for on the outpatient side, so that we could get a correct kind of outpatient, an equivalent measure to inpatient NPR per CMAD on the outpatient side, but we're working on that. There's potential data sources that we're looking at to be able to do that calculation and be able to take a look at both inpatient and outpatient.
Yeah, I think I understand the barrier, but I think working on taking some of the major categories such as ED visits, such as outpatient surgery, and having some data on that would be critical. I think when you think about, for example, excess cost due to low value care, I think unnecessary emergency room visits is a big driver of that, and visits that could otherwise be handled by primary care or urgent care. So I'm hoping over time this will get richer in terms of insight into outpatient, because I believe that for most hospitals, outpatient margins are much higher than inpatient margins. And so by not having any metrics on outpatient here, I think you're missing a big part of the picture.
Yeah, that's right, David. Outpatient is a growing area. The benefit is we are having additional data sources, including the HPD. There will be, in the future, there will be additional reporting, kind of how the state is overall performing on various measures, including inpatient and outpatient.
Mariel Reytaza.
Hi, me again. So, I really like this discussion. I think this really gets to the heart of so many things that we need to look at. One thing that strikes me is that in these metrics, none of them really involve outcomes. Is that something that we're going to incorporate? Because, we spend so much on healthcare, yet don't have the outcomes to show it. So I would really love to see some kind of integration with that in this data, if not in this iteration, in upcoming iterations.
Yeah, so we'll be having a discussion this afternoon. We do have a requirement for equity and quality measures, and we do have inclusion of a number of hospital measures that we'll talk about.
Thank you. Appreciate that.
Okay, back to the presentation.
Great, thanks all. Really appreciate the feedback and insights. Okay, so before we get into some descriptive statistics, I'll just reiterate one more time. This isn't a proposal in any formal sense from OCA. It's simply a way for us to present information to help facilitate discussion. And so here we'll include some summary statistics on the next slide, just providing some high-level takeaways for the top 30 across the 5 metrics, as well as statewide medians. And so this section of these slides will be that without specified inclusions category. And so going down the rows here, we could start with the average inpatient NPR per CMAD. So from 2018 to 2022, there was a high of $402,000, and then the 30th hospital had an average of $28,000 with a statewide median weighted by inpatient discharges of $13,000. The next metric here, so average commercial inpatient NPR per CMAD. So the top 30 hospitals range from a high of $107,000 to $36,000 with a statewide median of $18,000. For the average growth metric here, the top 30 hospitals range from 79% to 15%, and the statewide median during that 5-year period was 2%. For average operating margin, the top 30 hospitals range from a high of 41% to 15%, with a statewide median of 3%. And then finally, for the average commercial to Medicare payment to cost ratio, the top 30 range from a high of just over 850% to 300%, with a statewide median of 204%. All right. So now we will get to some fairly involved tables. So I'll do my best to walk us through these. Again, if folks have questions, please don't hesitate to ask. So here on the slide, we have the top 15 hospitals ranked by average inpatient NPR per CMAD without any of those specified exclusions. And so for this first metric, most of the hospitals are those with stays longer than 20 days. About half are small hospitals with less than 100 beds. There are 4 critical access hospitals, 4 psychiatric hospitals, 2 children's hospitals, and 1 teaching hospital and 1 specialty hospital in this group. Circling back to some of the comments earlier, about half of these hospitals fit into more than one category. And then finally, with respect to regional dispersion, most are in metropolitan areas like Los Angeles and the Greater Bay Area. And then others have noted sort of the potential volatility from small sample sizes. So just to kind of take that first entry there, that first record of Children's Healthcare Organization of Northern California Pediatric Hospital, it has about 15 to 25 total inpatient discharges in a given year. And so it can produce incredibly volatile averages during that 5-year time series as a result of that small number of discharges. And we can move on to the next slide. So this will include the top 16 through 30 on that same average inpatient NPR per CMAD without any of those exclusions. Here again, the majority of those hospitals have stays longer than 20 days, so about 11 of them. Slightly more than half have less than 100 beds, so based on our operationalization, they'd be considered small. 4 are critical access hospitals, 3 are specialty hospitals, 3 are public hospitals, 2 psychiatric hospitals, and then finally a teaching hospital. And again, that's sort of transcending across categories. 11 of the 15 fit into more than one category. With respect to the geographic distribution, so we have hospitals not only in LA and the Bay Area, but also in some of the more rural parts of the state, such as Inyo, Plumas, Glen, and Trinity. Okay, moving on to now just sort of the decomposed version of that pooled metric to focus in on commercial inpatient NPR per CMAD. So here we have the top 15 once again. This list includes 1 critical access hospital, 9 hospitals with less than 100 beds, 2 children's hospitals, 3 teaching hospitals, 2 specialty hospitals, 2 psychiatric hospitals, a public hospital, and then again 9 hospitals with long average stays. So those hospitals with greater than 20-day on average lengths of stay. And then 9 out of the 15 hospitals transcend categories. At the county level, so mostly seeing again LA and Bay Area facilities, though there are some hospitals in the Central Coast and San Bernardino. This, I think, is another illustrative example to understand how a 5-year time series can produce, particularly during a pandemic, can produce sort of unusually large volumes here. So to take on this one, I'll pick on row number 3. So West Covina Medical Center, for example, during that 5-year time period, their commercial NPR ranged from a low of 26,000 to a high of 160,000 on average. And so you end up with a rather high average across that 5-year time series. Okay, going on to 16 through 20 here. So here, again, there are 4 hospitals with less than 100 beds, 3 teaching hospitals, 2 specialty hospitals, 3 public hospitals, and then 8 with long average stays, so those greater than 20 days on average. And then 7 out of the 15 on this slide fit into more than one category. With respect to the geographic distribution here, it's quite diverse. So you have facilities from Orange County in Southern California to El Dorado and Marin, as well as parts of the Central Coast and Central Valley. All right, let me pause there before we move on to the next metric just to see if there are any questions before. Yes.
Travis Lakey.
Is there a way to split that up by average charge per day? Because speaking as a critical access, we have swing beds and skilled nursing facilities, so it really skews the data because they're with us for a really long time.
We can take that one back. Yep. We're not going to be able to do that in real time, but yeah, that's an action item that we can work through. Thanks.
Joan Allen.
Have you looked at how much volatility there is in the list for different time periods? So taking a 5-year slice, say 2012 to 2017, and just seeing are these lists pretty constant, or are we seeing a lot falling in and out? That would be helpful to see, and similarly seeing how much the list changes once we include 2023. So I know I know we're still in the more preliminary 2023 data, but it feels like it was a very different year than 2022. So have you done those, and is it possible?
So currently, for the past, for December and the January meetings, we have focused on this 5-year time series from 18 to 22. As you note, we are eagerly anticipating updating the time series to include 2023. We have not gone further back in time. That's something that we could do. There's some level of effort there, but I think certainly top of mind would be folding in 2023 as it becomes available.
David Joyner.
I don't have a good answer for this question, but I'm hoping you've got some insight. So how are you thinking about county hospitals, for example, Zuckerberg San Francisco General Hospital? You know, to my knowledge, generally speaking, their focus is to serve Medi-Cal and Medicare patients, and they really don't contract with commercial health plans, but they do see some commercial members through being admitted through the trauma center or otherwise. And so their costs are very inflated for commercial because of the strategy, and it is a real cost for commercial, but it's not quite apples to apples to a hospital that's contracted with a health plan who has negotiated rates. So how are you thinking about this? You look at, you know, cost per inpatient day.
Thanks, David. And that's why we started with the discussion of sort of naming these particular types of hospitals and trying to get both the board's input. So we've had a number of meetings to get the board's input and welcome your input as well to raise issues like that. Yeah. So I think we understand there's some differences, and so that's why we start with that frame.
Yeah.
And Andrew will next, you know, once he gets through each of the different calculations without exclusions, we will show you some exclusions that the board, you know, had initial inclination to exclude certain types of hospitals. Yeah. I don't know if there's anything you want to add, Andrew.
All right, on we go to the next metric. So this will be annual growth in inpatient NPR per CMAD. So here we have the top 15. 10 of which are small hospitals, 9 are long stay hospitals, 4 psychiatric facilities, 3 public health hospitals, 2 critical access hospitals, and then a specialty hospital. And 11 of these 15 stratify multiple categories. So here again, fairly diverse group of facilities that includes just about every region of the state, from the Bay Area and Los Angeles to the Central Coast, Central Valley, and the northern part of the state. Here again, I'll provide a little bit more color to something that Andrew has noted about the volatility here. So we can take that first facility there, Sonoma Specialty Hospital. So a 79% average annual growth rate across the 5-year time series, largely driven by the change from 2020 to 2021, where in 2020, the average inpatient NPR per CMAD was $11,000. It shot up to $31,000 in 2021, so 175% growth rate year over year, and thus you end up with a rather large average across that 5-year time series. Okay, on we move to to the 16 through 30 list here. And here again, about 10 of those hospitals are considered small with that 100 or less bed count, 7 long stay hospitals, 5 psychiatric hospitals, 5 critical access hospitals, 1 specialty hospital, and 1 public hospital, and 10 of the 15 transcend one category. Okay. And again, a pretty diverse group of hospitals from Southern California all the way up to the northern part of the state. We can move on to our penultimate metric here of average operating margin from 2018 to 2022. So here we have the top 15, of which 9 are we'd classify as small hospitals. You have 9 psychiatric hospitals, 4 specialty hospitals, 2 long stay hospitals, and then 1 children's hospital, and 8 of the 15 fit into more than one category. And with the exception of Merced here, the group is primarily clustered in Southern California and the Bay Area. All right, on we go to hospitals ranked 16 through 30 on average operating margin. So here we again see 4 small hospitals, 3 critical access hospitals, 2 specialty hospitals, 2 psychiatric hospitals, and 2 long stay hospitals, and 4 of this group fit into more than one category. A bit more geographic variation here, which we see there's the inclusion of the Central Coast as well as the northern part of the state, with Plumas and Trinity counties being included. All right, home stretch all, final metric here. So here's the average commercial to Medicare payment to cost ratio. So just as a reminder, so here we're effectively comparing the commercial payments to those received to Medicare. And so to use an example here at the top of the list, Monterey Park Hospital. So you can interpret that 857% to mean that for this hospital, the cost coverage was about 8.5 times better for commercial patients than it was for Medicare. Here again, I feel like a broken record here, but just to dwell on how a 5-year time series that includes 2020 can produce unusual volatility. So Monterey Park's Medicare payment to cost ratio was 12% in 2020. It dropped from 69% the following year. And so those kinds of year-to-year swings, right? In 2020, their commercial and Medicare payment to cost ratio was in excess of 2,000%. And so average across 5 years, it produces a rather jaw-dropping 850% average across that 5-year period. Here, looking at the hospitals by their facility attributes, 5 are small hospitals, 1 is a critical access hospital, 1 is a children's hospital, 1 is a teaching hospital, and 1 has a long average length of stay. And then 2 of the 15 here fit into more than one category. And then again, county, in terms of the county distribution, we see quite a bit of diversity across the state. All right, finally, 16 through 30 here on our average commercial to Medicare payment to cost ratio metric. So here we have 4 small hospitals, 2 teaching hospitals, and 1 specialty hospital. And 1 of these hospitals fits into more than one category. So not quite as much Southern California concentration here, but we do see a lot more of the northern part of the state bubbling to the top here, including Amador and Central Valley, as well as Stanislaus and San Joaquin. All right, before we move on to the same set of descriptive statistics, just with exclusions applied, we'll pause here and see if there are any questions.
Thank you. I'm just curious how we're classifying Northern California. I go through this so much at various tables, but the farthest north I'm really seeing is El Dorado, Sacramento. There's another 4 hours of our state beyond those. And I'm not really seeing much. I got a little glimmer of hope when I saw Plumas in there, okay? And I saw Glenn in there. But beyond that, there's still another 3 hours of our state. So I run into this constantly where there's this void of attention to those areas because they're more sparsely populated, but we still have the same affordability challenges. And I'm trying to figure out what will it take for those regions not to drop off of the statistics consistently just because we're classifying north as ending at Sacramento. This is a 500,000 plus population. When you head to Modoc County, you're looking at 8 to 10 people per square mile, and they still need coverage. Their children have to travel 5 hours to get medical care. That's not acceptable.
Thanks very much, Carolyn, and we're glad you're here to represent those areas. And so, you know, we've included any hospital. This is just the data as it when we did the calculations by the metric. So Andrew didn't exclude any hospitals based on region. So these were the ones that rose to the top when we did the calculations.
So is that meaning they're the most expensive ones that come up?
Yeah, these are the top 30 by each of the different metrics that we applied.
Okay.
Yes.
All right, that's a little bit better. At least we're not the most expensive.
I see Kieran Savage-Sangman's hand.
Yeah, just a quick comment. I'm struck on the operating margins by the number of psychiatric hospital facilities that are in that top 15, even top 30. That really stands out to me. And I don't know exactly how this works, but it makes me wonder if there's sort of a deep dive that OCA could be doing into why our psychiatric hospitals are operating with such significant margins at a time when we're having such difficulty accessing that care, and sort of what that looks like, and that the state's putting pretty significant investment, state dollars, into psychiatric health facilities through Prop 1, et cetera. So I just want to raise that for future, and also I hope we can sort of keep that in mind when we get to the behavioral health investment benchmark discussion about where we really need more money or not. So just comment.
I see Sarah Sorokin's hand.
Yeah, I'm glad Kieran brought that up because I was kind of struck by the number of psych hospitals. A lot that I recognize just from patients in Solano County where I work being discharged from into our system, and just kind of a descriptive side note maybe of a lot of the clients, and I'm part of the assessment team, so I do initial assessments for people entering our system or re-entering. A lot of the hospital discharge patients, they're discharged from hospital to outpatient. So, and there's a lot of no-shows, over 50%. So there isn't much of a step down of support for them. And also, a lot of times I'll assess people who are clearly suffering greatly and in need of a lot more support. So it does make me kind of wonder, like, how explaining the cost and knowing that a lot of psych hospitals are staffed by like psych techs or mental health workers who aren't at master's or doctoral levels. And so I know they get paid quite low. So just something that I also wanted to mention.
Thank you. Simona Reddy.
I want to third that, patient side and personal side, before I tear up on that one. I think there is something going on with psychiatric hospitals and quality of care and cost that seriously needs to be looked into.
Thank you. Yes, Mariel Reataza.
Yeah, I appreciate this discussion. You know, we can invest a lot in mental health care and you know, providers and such and hospitals, but you know, the fact of the matter is that if people are suffering because there are factors out of their control, they will continue to keep suffering. And you know, I don't want us to lose sight of the fact that if we are in an economic state where people can't have stability in their jobs or homes, which is what we're seeing rise, we're going to see more and more people suffering from mental health conditions and substance use disorder. That's something that, you know, we know is going to happen. So we really have to look at what's happening here. What are we calling, you know, really mental health, behavioral health services, right? Because again, the data show that most people who could benefit from behavioral health services don't actually show up. So we have all of these things, but who's coming to them? Very few. So we really need to rethink about that, rethink what that looks like.
Thank you. Okay, back to the presentation.
Great, thanks. And so now we will begin the same review of metrics, but excluding several facility types. Before we get to that, however, just briefly provide some high-level descriptive statistics here. And so this is now the same 5 metrics with the exclusion of critical access hospitals, children's hospitals, psychiatric health facilities, small hospitals, those with less than 100 beds, and then those hospitals with long average stays in excess of 20 days. And so starting with the average inpatient NPR per CMAD, the top 30 ranged from a high of 54,000 down to 18,000, and the statewide median here, weighted by total inpatient discharges, was about $13,000. Turning then to its complement here of commercial inpatient NPR per CMAD, here the top 30 range from 57,000 on average to 28,000, with a statewide median of 18,000. Next, our growth metric here of inpatient NPR per CMAD in annual growth terms range from a high of 66% down to 7%, with an average statewide, or the statewide median of 2%. Next, average operating margin for the top 30 hospitals range from 39% to 12%, with a statewide median of 3%. And then finally, average commercial to Medicare payment to cost ratio on average from 2018 to 2022 among those top 30 hospitals range from just over 850% down to 276%, with a statewide median of 208%. All right, so this format I suspect is familiar at this point. So this will be the top 15 hospitals ranked by average inpatient NPR per CMAD with those aforementioned exclusions. And so here there's a slight change in that we're using color shading to denote for the top 15, if you see dark blue, that would denote them being ranked in the top 15 on a given metric. And then if the output is ranked between 16 through 30, it'll be a lighter shade of blue. So looking at the descriptive statistics here, more than half of these hospitals, so 8 of the top 15 here, are either public hospitals or those designated as teaching hospitals or academic medical centers. In terms of their geographic distribution, 11 are located in LA County or the Bay Area. And then of the hospitals appearing in this top 15, 6 also appear as in the top 30 on another metric. And getting now to the top 16 through 30, ranked by average inpatient NPR per CMAD, with those aforementioned exclusions. So 5 of these hospitals that appear in the top 16 through 30 are designated as either teaching hospitals or academic medical centers. 12 are located in LA County or the Bay Area. Just to be precise, Bay Area including San Francisco, Santa Clara, and Alameda counties. And then of the hospitals appearing in the top 16 through 30, 9 of those hospitals appear in the top 30 on another metric. We can now move to our second metric here, commercial inpatient NPR on average from 2018 to 2022. And so looking to the descriptive statistics here, we see that 5 of these hospitals in the top 15 are designated as either teaching hospitals or academic medical centers. There's 1 specialty hospital and 4 public hospitals. And most of these hospitals are generally in the greater Bay Area. And then of the hospitals appearing in the top 15 here, 13 also appear as in the top 30 on another metric. All right, 16 through 30. So here we have 4 of the hospitals that appear in the top 16 through 30 are designated as either teaching hospitals or academic medical centers. You have 1 specialty hospital and 2 public hospitals. 11 of these hospitals are in the LA area or Bay Area county. And then of the 16 through 30, 11 also appear in the top 30 on another metric. Okay, on we move to our annual growth in inpatient NPR metric here. So looking at the descriptive statistics here, 3 of these hospitals are designated as either teaching or academic medical centers. 3 are psychiatric hospitals. And then 6 of these hospitals are considered public hospitals. And then 14 are located in either Southern California or primarily Southern California, so LA, San Diego, Riverside, San Bernardino, Orange County, and Ventura counties. And then among these 15, 7 also appear in the top 30 on another metric. All right, 16 through 30 here. So of these hospitals, we see that 5 appear in the top 30 on another metric. And 11 of them are also located in the southern part of the state, so LA, San Diego, San Bernardino, or Orange counties. Next metric here is going to be average operating margin. So among the top 15 here, 6 are psychiatric hospitals. And then of these top 15, 6 also appear in the top 30 on another metric. (16 through 30). Okay, here we see among this second ranked batch here, 6 of these hospitals appear in the top 30 on another metric. And again, you see a fairly high concentration of Southern California facilities, though there are also some Bay Area counties included on this list as well. Okay, last metric here. So the average payment, commercial to Medicare payment to cost ratio with those aforementioned exclusions. So here we could see that among this top 15, 7 also appear in the top 30 on another metric. And you see a fairly diffuse set of facilities from Southern California and Los Angeles County in particular, as well as the Bay Area. All right, finally, 16 through 30 on that average commercial to Medicare payment to cost ratio metric. And so here again, we see 2 teaching hospitals that appear in the top 16 through 30 rather. And then of these 16 through 30, 5 also appeared as top 30 on another metric. All right, we all survived. So we can now open it up to see if the advisory committee has any input on the data and as well as the metrics that were shared.
forgive me, I see Mariel Reyes-Taz's hand, Andrew C., Barry Arbuckle.
Yeah, thank you so much for this very comprehensive explanation of data. Something that strikes me is that I'm surprised that there are much fewer Orange County facilities that I expected. I also want to comment that UC Irvine, which is the only academic center in Orange County, is not listed here. So I'm very curious, like, what's happening? What's that discrepancy, right? Because you can see all of the other UCs kind of coming in here with their centers. So I would love to know, where does UC Irvine Medical Center fall here? Obviously not in these rankings, but what's happening there that is precluding them from appearing on these lists?
Yeah, thank you. So, I mean, again, the staff did a lot of, and I just really want to thank Andrew and Vishal and Andrew's team for doing a lot of work really digging in on this, looking at different ways. So, I mean, the data speaks for itself. So we used the hospital financial data, which is audited. I think there's a longstanding understanding that that healthcare costs are higher in Northern California than Southern California, and so we're just reporting the data as we have run each metric.
Thank you. I appreciate that. I guess just to further this conversation, I'm curious to see, right, for the hospitals that didn't make it, again, I'm just looking at academic centers because that's one thing that's very clear for me, at least when I think of academic and research, again, why all of the other academic like UCs appear here, but I'm not seeing UC Irvine. I would love to see like why that is so, because I think that's a huge data discrepancy. That's an outlier.
Thank you, Andrew C.
So thank you to the team for putting this together. There's a lot of data. I appreciate it. I do have a question, and maybe I'm going to ask something that it's too much for a metric, right? So a lot of the metrics we've talked about, it's still rooted in fee-for-service, right? You're still talking about a per discharge. So you have an incentive to kind of lower a unit price. I'm not seeing an incentive to lower utilization or case mix, right? So we just have to be mindful of, what is the incentive we're creating here, right? It's kind of like, you've already spotted them for case mix adjustment. What is the incentive to actually manage that and lower the utilization? So it's just one thought.
Barry Arbuckle.
I appreciate all of this data. I actually enjoy all of this data, which might suggest I should have my head examined. Each of these metrics, each of the columns on your last slide, the last four columns that you walked us through, each of them would have nuances and caveats as to why they may or may not be as revealing or applicable as it might seem, and Dr. Chertel could probably give us an hour lecture on each one of them. The one that actually strikes me as kind of intellectually appealing but potentially wildly misleading is the average to commercial Medicare payment to cost ratio. And that is because there's a presumption that Medicare payment is somehow equitable, that it's somehow similar across hospitals for the same kind of patient doing the same kind of procedure. And as I raised at a meeting several meetings ago, that couldn't be further from the truth. I mean, just to put a pin on it and use, a real example, because sometimes tangible examples help these theories come into context. If you compare, say, two hospitals in my market, in the LA market, Cedars-Sinai and UCLA, they're both very large institutions, both tertiary and quaternary institutions, both doing an enormous amount of research, both have academic medical programs. The difference in Medicare base rate between those two hospitals, with UCLA's being higher, is not 5 or 10 or 20. It's now 48% difference. So when you use that cost ratio, they've got, their commercial rates can go a lot higher and still not show up on the radar. By example, if we take, just to make this point, if we take the UCLA base rate and increase it by a commercial to Medicare cost ratio that is below your threshold, so it wouldn't show up on any of these charts as being a hospital we should focus on, it would still have higher commercial rates. And I focus on commercial because most of our discussion here has been that's what impacts the consumers more than Medi-Cal and Medicare. It still would have a higher commercial rate than if you apply the second highest cost ratio in your chart to Cedars. It would still cost the commercial patient more at UCLA. And the same is actually true for a hospital. I believe it's been mentioned at every meeting since we convened, the community hospital in the Monterey Peninsula. Its Medicare rate is, UCLA's is 44% higher. And so it shows up on the charts in part because of that reason when we're comparing commercial and Medicare. So again, there's a lot of nuance to each one of these. That one kind of immediately looks like an appealing one to use, but it is fraught with I think, challenges.
Joan Allen, then Katie Basler, then Tam Ma, then David Joyner.
First off, thank you for the visualization. That is incredibly helpful and really helped me navigate what is otherwise a difficult set of data. One of the things that I did was to put the with and without exclusions lists side by side and was actually really surprised at how different they are. And I think one set of context that would be helpful for the discussion about exclusions would be just a little bit more nuance about which of the exclusions is driving those lists to be so different. I suspect a lot of it is the 100-bed cutoff, since that knocks out roughly a third of the hospitals in the state. And so just thinking in terms of, as we're thinking about the interplay between the exclusions and which metric we choose, just a little bit more nuance there would be helpful. Also, I do feel like the exclusions list gets us to a set of hospitals that have more ability to move the needle on cost. Really all of them. All of the metrics with exclusions have a list of hospitals that are much more recognizable and contributing to that statewide cost profile. Within that, I definitely understand the hesitation of using Medicare as a benchmark, and would encourage a little bit more investigation in that, because the average commercial to Medicare is quite useful. And then just that straight average commercial inpatient NPR per CMAD. But yeah, I think that just a little bit more data on the comparison between the exclusion and non-exclusion list would be helpful, or just, again, the spreadsheet.
Thank you. Katie Basler.
Thank you. As everyone has said, I'll echo that. Coming from Monterey County, it is later on in the presentation, there are additional slides, but I reflect on the fact that there are 439 approximately hospitals in California, and 2 of them consistently show up on one or both show up on these charts. And what I find interesting is our safety net county hospital, Natividad, doesn't, yet their rates for commercial insurance are equal to community hospital and Salinas Valley Health. It's just a reflection, and I would also like to express that the research that was presented at the August OCA board in Monterey County shared that the payer mix in CHOMP and Salinas Valley is not different from any other hospital similar to them. So thank you again for presenting this data.
Tam Ma and David Joyner.
Yeah, so I'd like to address some of the questions that have been raised by other members of the committee, but also in the context of these metrics, and particularly the inpatient net patient revenue per case mix adjusted metric for commercial revenue. And so for both the county hospitals and the UCs, we provide, in the commercial side, a significant number of trauma services, which tend to be high cost services. So that kind of skews the numbers there. And with regards to the UC academic health centers, we play a unique role within the healthcare delivery system across the state. The UCs see patients from 91% of California zip codes, and those are for the tertiary quaternary care that's usually not available at your local community hospitals or other hospitals in the region. And so patients end up having to be referred or travel to the UCs for very high cost specialized services such as trauma services, organ transplants. The UCs do half of the organ transplants in the state of California, care for very rare diseases. We operate the NCI designated cancer centers, treatment for hemophilia patients, CAR T cell therapy, sickle cell therapy treatment. So many treatments that really rely on high cost drugs, and that's an underlying cost driver as well that we don't have a control over. I think between the counties and the UCs, these hospitals operate 8 out of 13 burn centers in the state of California. Also another very highly specialized service that's high cost, that's not available at your average community hospital. And so all these factors drive how these hospitals, county hospitals, and the UCs show up in these performance metrics. And I really urge OCA to consider these factors as it's continue to refine and think about these issues. And then I'll just reiterate again, the issue around children's hospitals being embedded in a hospital. That is a large source of care, large services that a lot of the UC hospitals provide that are the same services that are provided at standalone children's hospitals. And then I'll also note that some of those standalone children's hospitals do refer cases to the UC children's hospitals because they may not be equipped to provide that level of care to the patients. And I think, and then I'll also just reiterate that OCA really needs to consider, the role that the designated public hospitals play in self-financing care of Medi-Cal, how those numbers get reported in the financials, and work really closely with DHCS to work through how those get measured and accounted for when you're looking at either enforcing the statewide target, considering additional hospital sector target, or even defining differences between hospitals within the hospital sector.
Thank you. David Joyner and then Hector Flores.
Yeah, I want to say thank you for all the analysis. It's fascinating. I'll tell you, my input would be when I look at these top 30 lists, I'm just struck by a lot of diversity, a lot of apples and oranges. And to me, like trying to look at a list which includes psychiatric facilities, very small facilities, large academic medical centers like Stanford and UCSF, it's just difficult to glean insight from that. So my suggestion would be, you've identified some of these sectors or categories. I'd rather see like the top 15 academic medical centers and the top 15 psychiatric facilities and the top 15 small community hospitals, and look at it from that point of view. I think it would be more insightful. The other thing I wanted to mention is Barry mentioned the commercial to Medicare ratio. I don't know how you're handling maternity, but for some hospitals, maternity is a very substantial number of the discharges. And obviously in Medicare, maternity isn't zero, but it's close to zero. The only maternity costs within Medicare would be those who are qualifying through disability. Over 65 obviously is not going to be contributing. So I'm just wondering how you're handling that, because I could see that skewing the data when you have hospitals where a large number of the discharges are related to maternity.
David, was the question about maternity services as they relate to the commercial to Medicare payment to cost ratio?
Yeah, I'm just saying one of your metrics here is the commercial to Medicare ratio. And I'm just asking, how are you handling maternity? Because there isn't really any Medicare maternity. There is plenty of commercial maternity, of course. for some hospitals, it's a very substantial portion of their discharges. So when you're trying to make that calculation, I'm asking how you make it in the context of.
Yeah, we don't exclude services, so it's kind of all revenue.
So my advice would be, I think you've got a mismatch between your numerator and your denominator.
Yeah.
And so I take a look at that, and is it skewing things inappropriately?
Yeah, we for the most part, it is a kind of established measure to compare rates. It doesn't work as well for children's hospitals, for example, because they may not have a high share of revenue. So we are looking into whether we should kind of create a threshold that you need to have this much revenue from each of these markets so that the measure is credible when we report it.
I guess what I'm trying to say is I think you're identifying these metrics to try to get insight. And I think with respect to hospitals with a high percentage of discharges related to maternity and to children's hospitals, you have a metric here where I would have concerns about its reliability, because you don't have a reliable denominator. You have a numerator for sure, but you don't have a reliable denominator because of the lack of services to Medicare patients in that category.
We hear the concern, David. I mean, there isn't a perfect metric, which is why the staff has done so much work looking at a variety of metrics. And so each of them have, issues. There are obviously some people on Medicare with disabilities who are giving birth. So there are not none, but certainly there are limitations on any of the metrics.
Yeah. And I understand there's no perfect metric. My advice would be, I think if you have insight into the percentage of discharges related to maternity, you might want to look into those hospitals that have a high maternity proportion, and is the commercial Medicare ratio misleading as a result? Because you've got the large number of dollars in the numerator and virtually none in the denominator.
Thank you.
Thanks, David Joyner. Next, Hector Flores, and then I see Mariel Reyes' hand.
Yeah, thank you. Like everyone else, I really enjoyed this discussion and the data that's provided. I know that our focus here is hospitals, but really we need to sort of look at things more systemically. The discussion we've had really speaks to the complexity of our healthcare system and the inequities that exist by geographic variations. So my recommendations for the OCA board and HCI to continue to trend things like the local variation of uninsured patients and Medi-Cal patients. For example, I trained at Kaiser. Kaiser does a great job. Not only is it a great system, but it also takes its fair share of emergencies through paramedic runs of uninsured patients, for example. But the big difference from a Kaiser system and White Memorial, where I work, is that White Memorial also takes its fair share of paramedic runs, but it also has a medical staff with groups like mine, where we have a significant number of Medi-Cal and uninsured patients, and we refer those patients for elective visits to the ER, or not elective, but emergencies, or urgent admissions to the hospital, and even elective admissions of uninsured patients, out of respect for the fact that the medical staff is there to serve the community and the hospital will absorb those costs. And that creates a conundrum. And part of this is obviously one of the answers is we need universal coverage. And something to trend is we've made tremendous headway on covering uninsured low-income families, including undocumented, with our initiatives of the past few years. But we need to look and to say, is that improving access to care in a preventive way, or do we need to go one step further, which is to also look at payment parity? Because if we don't have payment parity, those patients will still have access problems. And what we've seen in the early years of Medi-Cal expansion is that a lot of patients now have coverage and they're still showing up to the emergency room because they don't have a primary care doc, or they don't even know who their primary care doc is supposed to be. The second part is the difference for these systems is that we have an opportunity to look at the MCO tax and how that might improve access to primary care, or at least stabilize primary care practices. And secondly, does it improve access to specialists now that it'll be paying at Medicare rates? And then number three is, does it support the hospitals that are serving those patients, either through the money following the patient, as in the fact that most Medi-Cal patients are now enrolled in HMOs, And will that HMO be able to then pay a non-participating hospital a fair amount for the care of that patient so the patient doesn't suffer? And, we also need to look at adjusting what governs our Medi-Cal program ability to pay non-contracted hospitals, which is the Roger Amendment that establishes a base payment for Medi-Cal patients in a non-contracted hospital, which doesn't come close to covering their costs. So in addition to universal coverage, we need parity. And then number three is look at moving the needle towards the alternative payment methodologies that we discussed earlier today, which is really we need to have every patient in California enrolled in a way that pays in a equal way, but also enrolls them into an alternative payment model, because it's the alternative payment models that really generate the innovation of fully integrated systems, exclusive relationships between physician groups and hospitals, reducing a lot of the inefficiencies that occur when a hospital has too many customers to deal with. And also drives the innovation of common ground for ambulatory surgery center, urgent care centers instead of ER, freestanding diagnostic imaging centers, all of these things that will lower costs. If we're able to do that, a lot of the complexity we're dealing with right now is trying to look at geographic variations. It goes away because we'll have systems responsible and accountable for how those dollars apply. And it doesn't have to be all HMO. It could be accountable care organizations that are taking fee-for-service payment methodologies, but including some risk that aligns incentives for everybody. The last thing is that we're always going to have some entities that need to be excluded. For example, critical access hospitals, rural hospitals, they're always going to need to be subsidized for the work that they do because they are coming in sparsely populated populations, but they need to provide the full scope of services that occasional patient may need. Same thing with some of our public hospitals. So we need to be able to accept that. The MCO tax also has an interesting perspective, which is that when it fully matures, we'll have over $200 million available for expansion or creation of new residency programs in badly needed specialties, not only primary care, OBGYN, but also emergency room and psychiatry. So we need to prepare ourselves to trend that is, does that increased workforce with payment parity begin to eliminate some of the geographic variations we see on this? I appreciate the complexity of what HCI is trying to do in the Office of Healthcare Affordability, but we need to start trending those things. Otherwise, we're going to get mired in the details of these little complex ecosystems, and we'll miss the opportunity to actually make a really statewide transformation. So thank you.
Thank you. Mariel Reyes-Taza.
Yeah, thank you, Hector, for also bringing up primary care. A lot of people who have primary care providers often have to wait 3 months, several months, right, to see their own primary care provider. By that point, who knows what's happened, right? They're going to go to the ER or urgent care because they can't see their primary care provider. For those who have one, that includes me, right? So, and something else that occurs to me, right, when we're thinking about expenditures and what is considered necessary and what is considered maybe extravagant. So for instance, in my previous life in surgery, right, you'd have, let's talk about laparoscopic like gallbladder removals, right? So it's minimally invasive, and there's two different kinds, right? You can do it just the regular old laparoscopic way, or you can use a Da Vinci robot, which is a multi-billion-dollar robot. And who gets to use the robot, right? And I'm not just talking about the cost of the robot. It takes an hour to set up the Da Vinci, right? It takes another hour maybe to do the procedure, and then another hour to take it down. Right, because there's so much like wrapping that you have to put in sterilization, sterile fields. So what I'm saying is that that's a 3-hour procedure that's using a multi-billion-dollar equipment versus a regular laparoscopic cholecystectomy that takes about an hour. So who gets to have these surgeries? How do they get calculated into all of these costs? Because that happens. And we know that, right? Because we have all these developments of really great drugs, except most people can't access them because they can't afford them. So that also extends to procedures, what is considered necessary and, otherwise.
Travis Lakey.
So what's the deadline for actually establishing these sector targets?
Yeah, Vishal's going to go over the time. That's probably a good segue to go back to Vishal to talk process.
Sure. We just have about another set of slides on process and timeline, and that'll take us into public comment and then lunch. So we've looked at the data, and we'll shift to discussion about sector target definition and touch on some elements of target setting options. In the slides that follow, OCA will consider sector implementation, sector target implementation, defining other sectors, hospital sector options. We'll discuss a parallel timeline for both sector definitions and target setting, and then we'll wrap up with a staff recommendation. So going on to the next slide. Based on discussions with the board, OCA has developed options to enable the board to establish sector targets to address high-cost hospitals. These options focus on how to define and establish sectors. The office would return in subsequent meetings with options on establishing the target values. So the four options are: way to establish sector targets for performance year 2027 or later. The second option is to define the three Monterey hospitals as a sector and establish targets for those facilities. The third option is to establish a sector based on facility attributes and financial measures. The fourth one is to define all hospitals as a sector and adjust the sector target for select facilities. And going on to the first option. So one option is for the board is to wait to establish sector targets. So rather than do it for performance year 2026, to wait to do it for performance year 2027 or later. The statute, under the statute, the board shall define initial sectors by October of 2027 and establish targets in 2028 for performance year 2029. However, nothing precludes the board from defining sectors and sector targets ahead of this time frame. So were the board to wait to establish targets until performance year 2027, the office would come back in the spring of 2026 with proposals. So the statutory section that I described earlier is laid out here. And on the next slide, I'll cover some considerations for option one. Some things to consider when evaluating this option include all facilities will still be subject to the statewide spending target until a specified sector target is established. For many facilities, the statewide spending target will be a reduction in spending growth compared with historical trends. Waiting to develop a hospital sector target allows the office to direct attention to other efforts, such as attributing healthcare spending to physician organizations and spending target enforcement. To implement this option, the office and the board would continue to analyze existing data and evaluate approaches to implementing sector targets, including high-cost hospitals. And then going on to the second option, so this would be to define the three Monterey hospitals as a sector and establish target values for them. So I want to point out that per statute, the definition of the sector shall be promulgated in regulations. Once that's established, once that sector for the three Monterey facilities is established in regulation, then the board would adjust a facility sector target in comparison to other healthcare entities in the sector and geographic region. We put in the statutory background for that, which is kind of the provisions related to establishing sector targets. And then that second one, the B2 provision is the one I want to focus on, is the language about the board may adjust cost targets by healthcare sector, including fully integrated delivery systems, geographic regions, and individual healthcare entities as appropriate, when warranted, to account for the baseline costs in comparison to other healthcare entities in the sector and geographic region. So under this approach, we would be looking at kind of where those facilities are today and historically, and then adjust the target value for them accordingly. And then moving on to considerations and implementation for this option. So this approach would be narrowly tailored to address the high costs of 3 hospitals that have been brought to the public and the board's attention. Defining a much narrower sector would limit the board's ability to later adjust the spending target to only these facilities, because the statute only allows adjustments when warranted to account for the baseline costs in comparison to other healthcare entities in the sector and geographic region. So in other words, we would just be limited to adjusting the target for those 3 facilities. Various stakeholders would likely challenge why these 3 facilities are defined as a single sector when data show that there are other high-cost hospitals. So to implement this option, the board would vote to define the 3 hospitals as a sector at a future board meeting. The office would draft and seek to implement regulations defining the sector. The office would then return to the board with options for establishing target values for these hospitals within the sector. And then going on to option 3, so this option would be to establish a sector based on facility attributes and financial measures. So the board could define a high-cost hospital sector that includes a subset of hospitals based on facilities that are disproportionately high cost, define potential inclusion and or exclusion criteria based on financial metrics and facility attributes, and then establish target values for those facilities. Kind of the statutory authority is the same as the ones I covered before. We've added another provision, which is the last bullet, B3, which references the historical data that we would look at when establishing target values. And then some things to consider when evaluating this option include the board would need to decide which metrics should be used to determine which facilities would either be included or excluded in the sector. Not all attributes that may warrant inclusion or exclusion, for example, children's hospitals, public hospitals, are readily identifiable or defined in statute or regulation. Many are an artifact of self-reporting in the HCI financials. The board may need to develop definitions for these facility attributes and potentially how financial measures would be operationalized in the definition. So this approach may unintentionally include or exclude entities that may not warrant a different target from the statewide target. And then lastly, this approach would require additional time for OCA to develop and implement, and OCA would not be able to implement sector definition regulations and propose target values for performance year 2026. To implement this option, we'd continue to work with the board on developing a process based on financial measures and facility attributes for defining hospitals that would be included in the sector definition. Once the process for defining the high cost hospital sector is agreed upon, then we would promulgate regulations and then come back with some proposals for target values. And moving on to the last option. So this would be to define all hospitals as a sector and then adjust the sector target for select facilities. So if established as a sector, hospitals would be subject to the statewide target unless and until a board adjusts the target for all or a subset of hospitals within the sector. The statutory text in the first bullet is what I covered before. Want to highlight some of the next two bullets. We've italicized the authority for adjusting the target for facilities within the sector. And then the last bullet is what I covered before. And then moving on to considerations for evaluating this option. This would allow the board to consider unique attributes of each facility and adjust cost targets of each of individual hospitals, accounting for their baseline costs in comparison to other hospitals in the sector. It would enable the board to strategically modify, tailor, and adapt its use of the sector target tool to promote consumer affordability. It wouldn't limit the board to add additional sectors in the future. The board could decide to adjust the targets for all or a select portion of hospitals in the sector annually. The approach for measuring and reporting hospital performance against the spending target will be different from health plans and other provider types. So we've covered with you all before about how we're requiring health plans to report on their total medical expenditures. We've covered attribution approaches where they attribute members to a physician organization. So those are measurement approaches we've already laid out. Hospitals would be measured differently in that we're not relying on payer data to measure hospitals. We would rely on the HCI financials. Establishing hospitals as their own sector aligns with how they're going to be measured differently. And lastly, this option could be implemented to enable adjusting of sector targets as soon as performance year 2026. And then going on to kind of flesh out the timeline a little, implementation timeline for this option. So the office would present sector target definition options to the advisory committee, which we're doing in this meeting. We're proposing that the board would vote to define hospitals as a sector later this month. In February, the office would return with draft regulations of the board approved sector definition, present it to the board, and then seek approval by the Office of Administrative Law. We would also provide recommendations for target values in February's meeting. And then between February and April, the board would discuss appropriate hospitals for which to adjust the sector target. The office would also present proposed sector target values to the advisory committee for your feedback in March. There would also be a 45-day public comment period that would begin the day of the February board meeting. And then lastly, from April to May, I could go back one, the board would be able to vote on sector target values and any adjustments for the selected hospitals, before June 1st. And then the next slide is just more of a visual display of these timelines. Here we show kind of they'd both be happening in parallel, the sector target definitions and the target setting. OCA's staff recommendation is on the next slide. So So we recommend option 4. If the board intends to proceed with sector targets effective for performance year 2026, we recommend option 4. It would provide the board with the ability to consider the details and attributes of each hospital prior to implementing a target value that differs from the statewide target. And this option would allow the board to respond timely to facilities with spending trends that do not advance consumer affordability. So I'll turn it back over to the facilitator to get your feedback.
All right, David Joyner, I see your hand, and then Travis Lakey.
Thanks, this is Vishal. Very, very thoughtful, very detailed. I personally would recommend a different approach than what staff has recommended, because I think it gets very dangerous to start changing targets for unique hospitals. I think you're going to open yourself up to a lot of criticism for, are you being fair? Are you being reasonable? Are you just, are you responding to squeaky wheels perhaps? And so I would steer away from adjusting targets for specific hospitals. What I would do is I would try to establish sector targets by sector. So to me, as an example, academic medical centers have very different exposure to, for example, uncontrollable drug costs than other hospitals. And it might be that academic medical centers might have a different kind of target than maybe psychiatric facilities. So I would look at a sector by major category: psychiatric, academic medical center, rural hospital perhaps, specialty, and think about establishing a target for those sectors that's different from the 3.5%. But my advice would be to steer away from trying to set unique targets for unique hospitals, because I think you're going to open yourself up to criticism that that's not fair and equitable for those that don't get a special target.
Travis Lakey.
I think we're kind of rushing the sector targets just for the fact that we're missing all the outpatient data, and seems like we're kind of rushing into this, and there's so much discrepancy between the range of hospitals on there that is not consistent with what we've seen there.
Thank you, Simona Reddy, and then Stephen Shortell.
I appreciate David Joyner's comments, and I can see that perspective as well. And Monterey County, I just have a question back for you. I don't know if it's come up. I myself have not looked into the county hospital Natividad Medical Center's, kind of gradual increase there, because it seems like it was fairly abrupt the last few years. But I noticed in your short list there, all the other small local hospitals are represented, and I hadn't realized that before. So you have Me Memorial Hospital in King City, you have Watsonville Community Hospital not too far away, and you have Dominican Hospital. So the hospitals South Monterey County and Santa Cruz County. So I'm just curious about that geographic fact, and hopeful that if these few are targeted, perhaps the others will, what's come up on that, or has it?
Simona, is the question about the other hospitals in the Monterey area?
I just noticed that when we're picking on geography, it's interesting to me that every other hospital in the local area between those two counties is also listed when you look at the data this way. Sorry, should I repeat, or?
Yeah, I don't know, Andrew, if we have any insight to the data, but this is, again, just based on applying the metric.
Yeah, it's the top 30, so they may just be further down the list.
But I'm saying that all those hospitals are in your top 30. When you look at the exclusions, that's what's so interesting. I wasn't expecting to see that. They're coming up for the first time. So I just want to make that comment, and I don't know if you've noticed that specifically.
Yeah, I think we did get feedback from the board in December to provide sort of a broad county level analysis. And so that will be forthcoming at the end of this month to just show across a number of different cost metrics how different counties array.
All right, Stephen Shortell, and then Sarah Sorokin.
I think the discussion we've had this morning, the argument could be made for option 4 to support option 4. And I think the reasoning is that it offers really the most flexibility given all the uncertainties and still data to be looked at, et cetera. I really appreciate David's comment about going to all sector rather than necessarily the flexibility of doing something with individual hospitals within the sector. But that might be, I mean, the argument against that at this point would be that it's blunt. It's a blunt instrument. It's one size fits all within the sector. You may well find in this first year or so that there are some specific hospitals that could benefit from feedback that they are an outlier, and therefore that gives you the flexibility to do that, as opposed to setting the target for overall and then going from there. Another strategy would be to, you can change these, I guess, over time. So an argument along David's lines of set the target for the whole sector for the first year, gain that experience, and everybody's looking at it. We see we're competing, et cetera, et cetera. We're at this level, all the academic medical centers, all the rurals, and so on. So you get that maybe, and then see how that plays out, and then move in the next year to option 4 once you have that, where you see there are some outliers that just couldn't do very well despite, and then you change it to say, okay, from now on, we're going to go to more this option 4 and not for a whole sector. So just some ideas, some thoughts.
Sarah Sorokin, and then Kieran Savage-Sangwin.
I just wanted to ask some questions, partly to make sure I'm understanding or to improve my understanding. So for a hospital sector, would that not include Kaiser hospitals? I know there was discussion about it, and I still haven't been able to wrap my mind around whether they're included or excluded. And the main reason I'm asking is because I believe they're the largest commercial insurer in the state. So I would think that that would be very important to know what's going on there. And then, so with option 4, being able to defining all hospitals as a sector, and then setting target values that differ from the statewide target for select hospitals, that wouldn't be like uniquely calling out hospitals in as much as looking at those data points and the hospitals that are the most costly, they would be subject to a more specific target, and you could look at the attributes of them to see if it explains maybe their outlier, but it would be like a systematic process.
Yeah, you described it right. And your Kaiser question, they wouldn't be included in the hospital sector definition, so they kind of have their own definition in statute. So if the board wanted to apply a different target value to Kaiser, they would first have to define a fully integrated delivery system sector, and then kind of go through the similar process we're going through now.
Kieran Savage-Sangwin, and then Andrew C.
Yeah, I really appreciate you laying out these staff is running option 4, which seems like it can encompass options at least 2 and 3. So it seems like it gives you the flexibility that's needed when we're looking at all of the different considerations that you laid out in the last 25 slides, right? Like being able to take all of that into consideration. And to Katie's point, I think the data that you presented in Monterey was really compelling in terms of these highest cost hospitals they're not high cost for any good reason is sort of what that data showed, right? And so I don't know, there has to be a way to say actually the 3.5% is not going to be good enough in those places where I haven't done the math, but if they continue to increase their cost 3.5%, I mean, it's really getting out of hand for consumers, and something has to be done. I think the other thing that's important, that at least my understanding about option 4 is that then you'd have more flexibility to act I think, more quickly to particularly egregious situations, which I think as we see how quickly the healthcare industry is changing, how quickly private equity is increasing, what we might see in terms of federal deregulation, like it's going to be really important for the board to have some flexibility to tackle these things in California in a timely manner to try to advance its prime mission of consumer affordability.
Thank you. Andrew C. and then Tam Ma.
Yeah, I just remember last year's conversations when we were discussing the statewide target, right? So we came up with kind of the same justifications of, well, can we make adjustments for this and that? And I mean, the staff and the board came down with, no, you shoot for an aggressive target. And retrospectively, if you miss it, then you have justification. So I guess I'm proposing a 4B, right? Everybody get the same target. If you miss it, it's retrospective. You have to come up with justifications because otherwise it gets hard, right? Prospectively, you're going to, as David said, somebody's going to say, what about me? What about me? And it becomes very unwieldy to come up with very exact criteria, that will not be subject to criticism. Just one man's opinion.
Thanks for that input, Andrew. And just to clarify that the process will be the same regardless of what the target is. So if the board does choose to set a hospital sector target for some hospitals at a lower value, there'll still be a look on the, as you say, a retrospective look as to what might justify those increases.
Excuse me, Tam, then Joan, and then Katie.
Sure. Can you remind us where we are on the hospital spending measurement work?
So we spent most of the year with the measurement work group. We received feedback on our provisional measurement approach, which would use the HCI financial data. So the metrics that we showed you today for the inpatient NPR per CMAD, we've gone over that with the board and gotten their feedback. We did have an outpatient component that would have leveraged inpatient intensity to calculate kind of that unit, outpatient unit, because we needed kind of a denominator and reporting kind of a per outpatient unit. The feedback we received was that you need to kind of have a better way to get to the case weights or the resources used to provide outpatient care, so we could have more precision on the numbers we would report on the outpatient revenue side. So we're still taking that feedback back and working through that, but would return to the board later in the year to how we've addressed the outpatient side. So that's the measurement piece, which would happen in parallel with kind of the discussion on the targets and sector target definitions and target setting.
Yeah, and so you say like going back to the board later in the year, so it sounds like you won't be finalizing like the hospital spending measurements till later this year stuff. And I think just in consideration of that, and I know there's been a lot of work go through that. There's a work group that has been meeting fairly regularly. I would encourage to focus on finalizing that work, and I think it's really challenging to think about or consider like having like hospital sector targets when we don't yet know how the spending is even going to be measured. And I think it's just the office has done a lot of work, and there's still a lot of other moving pieces too about how even the statewide target's going to be enforced, right? How those costs will be considered, and I think the baseline report's supposed to be coming out this year as well too. So I feel like there's just like more information and thought that we need to put into all of this work to consider all the different nuances and issues that's been raised here by the committee today. And so I think I encourage kind of focusing on getting those pieces done, and so that we can even understand how healthcare entities, right, all entities, not hospitals, health plans, and medical groups stuff, are even how they fall when we're looking at the 2025 target and the 2026 target next year when it's enforceable, before we start digging into additional layers here.
Thank you. Joan Allen.
Echoing Kieran, I appreciate the board's recommendation on option 4 and would support that. I feel like it gives us the most flexibility and also preserves the timeline for being able, for the board still having the option for the 2026 year to move forward with a hospital sector target, whether that is for the sort of subsectors that David was speaking to, or whether it is the Monterey hospitals or some other grouping. It gives us the most flexibility, and I appreciate the staff's careful work on figuring out how we can get this done for 2026.
Thank you. Katie Basler.
Thank you for that, Joan. I represent educators, and we have a severe staffing crisis statewide in education. We don't have college graduates interested in going into education because of the low pay. You add on the cost of health care, and it's impossible for them to start. I support option 4. I think it gives the board and OCA flexibility, but there is urgency if we are going to start to take care of an industry such as education that is the cornerstone of all of our communities. And there is urgency. I will mention as an aside that Kaiser just came into Monterey County. We have not had an HMO since the late 90s. But the Kaiser in Monterey hospital is Watsonville. There are no specialists, and they are not accepting Medi-Cal. So it's not going to help our hospital systems anytime soon. So I urge the option 4, because I think that it addresses the hospitals in Monterey County, but also gives flexibility if you find more data. So thank you.
Thank you. Carmen Comstein. That's the last hand I've seen at this point.
Yeah, I just want to echo what others have said, that option 4, appreciate the recommendation from the staff on option 4, because it does, I think really the discussion today is, you can look at the data any which way, you can look at the definitions of hospital facilities by various types in a number of different ways, and I think we haven't found our grounding on what the different attributes, if they should or should not have their own targets. But I think option 4 allows the board to be able to move forward with looking at specific situations like in Monterey County, and we can do option 2 as a test case in terms of how to actually put together a specific special target for a certain type of whether it's I know the Monterey kind of example is regional, but I think it's a good way to kind of move the ball forward in terms of figuring out what it means to have either a facility specific or a sector specific target, and I think the data that has already been built on the Monterey hospitals really kind of presents itself as an opportunity to do that and to do it quickly, and I think appreciating David's comments about what's fair and what's not fair. I think the onus should be on at this point on the facilities to prove that they need a different target. I think that's really where we're at this point, and that we shouldn't be taking that broad brush of all these various definitions that we were playing with today. Thanks.
I do see one more hand from Adam Doherty. Please go ahead.
Sorry, trying not to delay lunch for everybody. But I'm in favor of the 4B suggestion as well. Thinking about those subsector targets, say, not just for, the highest cost facilities like we've discussed, but, also creating room for opportunity there. So looking at the higher value systems, highlighting those, allowing for that development of, primary and preventive care and investment that we need to ultimately get to the longer term, bending the curve. So, looking at best practices in addition to the stick approach that we're discussing.
Thank you. Okay, with that, I think we'll go to public comment regarding item 4 before we break for lunch. So appreciate individuals in the room lining up near the podium. If you'd like to make public comment, if you are attending virtually, please use the raised hand feature at this time so we can appreciate how long the queue is. Please keep your comments to 2 minutes or less. And with that, we'll turn to the individual in the room.
Yes, Beth Capel for Health Access. First of all, you have had hours of discussion on extremely complex stuff without allowing any public comment. So in that context, to limit our comments to 2 minutes is problematic. And let me now turn to the substance. We too support a version of option 4. I think the phrasing perhaps in the recommendation could be strengthened by the law contemplates high cost outliers, but we know from the other presentations we've sat through on this and the work the staff has already done that there will be consideration of criteria and measures in detail, and that's what a lot of what you set through. I will say also with respect to the types of hospitals, the categories of hospitals, these are self-identified, and there's a lot of idiosyncrasy in the self-identification, some of which dates back many decades. Health Access opposes almost all of whatever you call them, exclusions, exemptions, exceptions. There are different considerations depending on the metric. For example, and I think children's hospitals and Medicare would be a classic example. We are strongly opposed to anything that excludes small hospitals defined as fewer than 100 beds. We do recognize that very small hospitals, more on the order of 25 or 30 beds or some small number of discharges, however you wish to measure it. But the LA Basin has a lot of hospitals that are 100 beds or so because of the development in LA post-World War II. So excluding all those hospitals has a disproportionate geographic effect in California that it might not have in other states. Also, to remind us all that the board and staff have already decided that we will measure target performance by market segment, Medicare versus Medi-Cal versus commercial, just as Director Landsberg reminded us that we're not exempting any hospital from the statewide target. The conversation here is about how we get to a lower cost target for the high cost outliers, however we define it. With respect to Kaiser, the law requires the capacity to compare them by type of, the language gets confusing now. So we can compare Kaiser hospitals to other hospitals, the plan to other plans, and the physician organization to other organizations. It is correct that the target would be the system, but the data comparison should be sufficient. With respect to administrative cost and burden, about which we had a lot of discussion earlier, I am happy to tell this group that the Newsom administration at the Health and Human Services Agency is working on that with respect to implementation of the SB 770 report. So there is substantial consideration of that already going on, which presumably can come into this discussion at some point. 2 final points. When we look at things like operating margin, we think about individual facilities versus systems, and we also think about types of hospitals. An investor-owned hospital where they're skimming off profits is a very different entity than a nonprofit hospital system or health system. Finally, with respect to the hospital measurement work, we were part of that work group and happy to participate. I would echo what Mr. Pagani said, that most the work on the inpatient measurement side is relatively final, but there is more work to do to get a good measure on the outpatient side. To us, that does not provide an excuse for delay, and we encourage OCA, the staff and the board to move forward to actually getting costs down in a way that matters for consumers, as several of your advisory committee members have said eloquently. Thank you.
Thank you. Looking at the online members of the public attending this meeting, I see no raised hands. I'm looking back in the physical room here and I see no one lined up to speak. Just want to pause. So that concludes our public comment period. Just want to inquire whether it would make sense to then re-adjourn at 1:25, I think as planned, or I'll turn to you, Vishal. Okay, so 1:30 if we could, be back ready to start at 1:30 p.m. We'll be taking a lunch break.
And we apologize for not giving you a morning break. We will try to give you an afternoon break.
All right, let's reconvene. Thank you for being on time. The time is now 1:34. We're reconvening the afternoon portion of the meeting, and we are right on schedule. We will next get our update on cost and market impact review program. Not for this one.
Good afternoon, members of the committee, staff, and audience members in the virtual world and here. My name is Heather Klein-Hoganson. I go by she, her pronouns. I am one of 2 assistant chief counsels in the compliance branch of OCA. Today, I'm going to be giving you a short update on our cost and market impact review program, which is often pronounced CMIR. Since our last report in October, we've had 5 complete submissions, which I'll show you over the next 3 slides. That brings our total for 2024 to 10. And that's April through December, since we did not start our program until April 1. I'll compare that with Oregon, who has reviewed 15 this year. They noted in a recent report that nationally, there were 58 deals in 2024. So having 10 of them is a significant chunk. So on our next slide, I'm not going to go over the slide, but I just want you to have it for reference. These are the things we look at when we are determining whether or not we need to proceed to a CMIR. And basically is it going to have some negative effects, or is it going to impact competitiveness? So on the next slide, we'll go to the complete submissions since our last report in October. And I say complete, we've had 5. We still have 4 pending submissions. It would be premature of me to talk about those because they are not yet submitted, but when they are, and that might happen in the next month or so, they will also be on our website. All of the details about these transactions are available on our public website. So the first one was AltaCare, and that's a skilled nursing facility in Orange County with 129 beds. That is currently under review. The next one is the Korean American Medical Group and Swan Practice Holdings. It's an IPA operating in Los Angeles, Orange, and Santa Clara counties. The next slide shows CSI Medical Group. That's looking at dermatology and plastic surgery as a physician group. And then below that is Ambry Genetics and Tempus AI. That's looking at risk screening laboratories. And then the next slide shows KTLA Properties. That's a 142-bed skilled nursing facility in Orange County, Anaheim. And that review has completed, and we have waived going to CMIR on that one. So there are 4 still in review, 1 completed since last October. We've averaged about 22 working days for our review. So I know there has been concern in the past about how long these reviews would take. Would it hold up deals? So I wanted to give you that report that it's averaged 22 working days from the complete submission forward. And then further, we have our CMIR inbox. Since the last report, we've had about 39 questions to which we've responded, and 10 meetings that we've held because of those inbox inquiries. That brings our 2024 total to 117 questions and 23 meetings. The questions generally cover things like, do I need to file? Here's a fact situation. Or how do I make sure something is confidential? Or I've heard about this deal. Are you reviewing it? What are you doing? Have you heard about it? Our goal for all of these inbox questions is to have a response within 2 business days. Now, in terms of the potential transactions that I mentioned, both ones that are not yet complete, but we are working with the submitters in doing those, and in terms of what we are asked through our inbox, we will not be reporting on any potential deals. They may be with other state agencies. They may not be ready to review. The deal's terms might not be final. We are, however, working with our sibling departments, and we have reached out to parties in responses to some of the questions that come into the inbox about potential transactions. So with that, unless there are any questions, my report is complete.
We're looking for questions and comments from the committee for Heather. Barry, go ahead. Thank you.
Thank you for that report. The 22-day period that you cited is impressive. But if I recall correctly, all submissions to date, I think bar none, the CMIR has been waived.
That is correct.
Had it not been, what would the process have been before a response would have gotten back to the submitters?
So according to our regulations, we have 45 days to determine whether or not it's going to go to a CMIR. If it's going to go to a CMIR, we have 60 days to notify all the submitters of that happening. Then there is an appeal window at which time they can say, oh, you missed something or you're wrong. And that is a certain number of working days depending on a variety of factors. After that, it could go to a CMIR. We would engage economic experts. That would be a more robust review, 90 days, and then there could be an extension to that if needed. Mm-hmm.
Other comments or questions? Yeah. Joan, please.
With a year almost under your belt, how are you feeling like the statute and regulations are driving?
Well, we did notice that there was a loophole earlier. As we reported last October, we amended our regulations to include not just the parties to a transaction, but also the subject of a transaction may be required to file with us. And since that amendment, we have been getting more inquiries and more transactions. So we think that was a good change to make in terms of transparency for deals. You know, there's always more that we could hope to have at some point, but I'm feeling good about it right now.
Go ahead. I have a question. If there was to be a transaction where you're not notified, you find out it's happened, it should have gone through CMIR first. What's the process there? What powers do you have if a transaction wasn't filed and closes without any input from you?
So one of the things we do is we reach out to the parties, and it could be they just didn't know, they thought they were exemption, something else was going on. If they refuse to file, then we could go to the Attorney General's office and say, we need you guys to be our strong right arm, and they can take a number of court actions, injunctions. They could also seek to unwind the transaction.
Others? All right, seeing no additional comments or questions at this time. Go ahead, Carmen.
Do you all feel like you have enough staff and like does OCA, does the team that's working on CMIR think, you know, how's it going with implementation?
Right now, we've been able to accommodate the number of deals. We did recently go out for a number of positions that we are, you know, originally had planned for. We had just not yet filled them. So we may be hiring 1 or 2 attorney 3 or 4 classifications, and some financial staff in the long run. But for right now, we are handling our workload.
Okay.
And appreciate your concern. Thank you.
All right. Any other comments or questions on this topic? Okay, that concludes this topic. We'll move to public comment on this item. If you'd like to make a comment, please step to the podium in the room. Online, please raise your hand. Seeing no one in the room at the podium and looking online, seeing no hands raised, that concludes public comment on this item. We will now move to the update on quality and equity performance measurement with Margaretta Brandt.
Good afternoon, everyone. So in this portion of the agenda, we'll provide an update and review the feedback we've received so far on OCA's quality and equity measure set proposal. And joining me this afternoon is Gianna King, Health Equity and Quality Performance Group Manager. So I'll review the first few slides and provide an overview and a kind of recap of where we are now, and then turn it over to Gianna. So yes, do that. And if we could go to the next slide. So as always, this is a reminder of our statutory language that guides our proposed quality and equity measure set. It indicates that the office adopts the quality and equity measure set, and that performance on the measure set must be included in our annual reports. It requires OCA to adopt and track performance on a single set of standard measures for assessing quality and equity across payers, fully integrated delivery systems, hospitals, and physician organizations. And these non-enforceable measures will be used to monitor quality and equity trends and promote quality and equity as the spending targets are implemented. The statute requires us to use The statute requires us to use recognized clinical quality, patient experience, patient safety, and utilization measures, and to consider available means for reliable measurement of disparities in healthcare, including race, ethnicity, sex, age, language, sexual orientation, gender identity, and disability status. And it directs OCA to reduce administrative burden by selecting quality and equity measures that simplify reporting and align performance measurement with other payers, programs, and state agencies, including leveraging existing voluntary and required reporting to the greatest extent possible. And the statute specifically directs OCA to coordinate with DMHC, DHCS, Cover California, and CalPERS, and consult with external organizations as we develop the measure set. So if we could go to slide 2, this is a bit more, or the next slide, a bit more about our statutory requirements related to enforcement of the measure set. So although OCA does not have authority to enforce the proposed quality and equity measure set or enforce performance on the proposed quality and equity measure set, statute specifies that OCA may require a healthcare entity to implement a performance improvement plan if spending targets are not met through its progressive enforcement process. And OCA's enabling statute prohibits the director from approving a performance improvement plan that proposes to meet spending targets in ways that are likely to erode access, quality, equity, or workforce stability. So accordingly, the director may consider performance on the proposed quality and equity measure set when approving or disapproving a performance improvement plan. And if we could go to the next slide. So this again is a reminder of the proposed purpose and focus of our measure set. So looking at promoting high quality and more equitable care for all Californians, monitoring changes in quality and equity as healthcare entities work to meet the spending growth target, and tracking progress towards OCA's goals of improving access, affordability, and equity for all Californians. So, and if we could go to the next slide, I'll provide an overview of our process and timeline before turning it over to Jana. So this slide provides an overview of the process that we've undertaken so far and are working towards, and the tentative timeline for developing and adopting OCA's quality and equity measure set. So in October of last year, we introduced our proposal for you all to gather feedback. And then in November, we introduced our proposal to the board and also gathered feedback there. Today, we'll provide an update of our proposal and a summary of the feedback we've received so far from you all and from the board. And we are also soliciting formal written public comments for 30 days following this meeting. So the proposal for OCA's quality and equity measure set has been released for public comment. And we've sent formal notice through the OCA listserv and then also posted the proposal to the OCA website last Friday and also included in your meeting materials for the advisory committee materials. So, and then I think as a reminder, we're aiming to adopt the quality and equity measure set by April of this year, though we can extend this timeline if needed for more development. And then by June 1st of 2027, OCA will publish its first annual report with quality and equity performance results using publicly available data. So now I'll turn it over to Jana to review the proposal and the feedback we've gathered from you all and the board.
Thank you, Margaretta. Okay, so this slide gives a high-level overview of OCA's proposal for the quality and equity measure set, and we've shown you this before. So we're proposing to adopt all or a subset of 3 publicly available measure sets and their respective stratification requirements to measure quality and equity across healthcare entities, including payers, physician organizations, hospitals, and fully integrated delivery systems. For payers, we propose adopting the full Department of Managed Healthcare's Health Equity and Quality Measure Set and stratification or grouping requirements. For physician organizations, we propose adopting a subset of the Center for Data Insights and Innovation's Office of the Patient Advocate, or OPA, Healthcare Quality Report Card measures. And for hospitals, we propose adopting the full HCI Hospital Equity Measures Reporting Program measure set and stratification requirements. Fully integrated delivery systems will be measured across all 3 measure sets, and OCA will apply the same benchmarks used by each measure set to evaluate the performance of healthcare entities. Now that we've provided a review of our process, timeline, and proposed measure set, we'll review the feedback that we heard from you all in October and from the board and how we're thinking about this feedback. Next slide, please. Okay, so a major theme of feedback that we heard from the advisory committee and the board was focused on adding measures, if possible, to the proposed measure set. And so this slide provides a summary of this feedback, which includes feedback to include more specialty care outcome and patient-reported outcome measures, actionable patient experience information, more access measures, including timeliness of getting needed care, more behavioral health measures, especially behavioral health outcome measures, cultural and linguistic appropriateness of care measures, structural measures, including social drivers of health screening for payers and physician organizations, and hospital safety measures. So both the advisory committee and the board remarked that current measures do not adequately measure population health and healthcare quality. Next slide, please. So what we've done on this slide and the next slide is to show the measures that are already in our proposal that fall under the categories that the advisory committee and board raised with us, including access, behavioral health, outcomes, patient-reported outcomes or patient experience, safety, and structural measures.
So these include some of the best available access, behavioral health, and outcome and patient-reported outcome measures for payers and physician organizations on this slide. And the next slide, we'll turn to the hospital measures. We want to note that the first 4 measures are also included in the OCA alternative payment model standards and are aligned across the DMHC, DHCS, Covered California, and CalPERS. And we also want to note that the process measures included focus on prevention and align with OCA's work promoting investment in primary care. Next slide, please. So similarly here, we've categorized the measures in our proposed measure set that are hospital measures to show the different types of measures, which include the best available behavioral health outcomes, patient-reported outcomes or patient experience, safety and structural measures, and our key measures for OCA to track to promote high quality and more equitable care. I'll keep moving, but let me know if we want to go back to these slides. Oh, next slide, please. So since OCA is tasked with using standard quality and equity measures, we will monitor new measures that are under development and consider adding these measures when they're fully developed and broadly adopted. There are several stages of measure development, and the timeline from conceptualization to implementation for measures is resource intensive and can take years. So this slide is showing that OCA will monitor work by leaders in measure development like CMS and Partnership for Quality Measurement. Partnership for Quality Measurement circulates a measures under consideration list on a yearly basis to gather feedback on measures CMS is considering adopting for use in quality reporting and value-based programs. And Partnership for Quality Measurement also convenes the Core Quality Measures Collaborative to create core sets in high priority areas, including behavioral health. Next slide, please. So OCA will also monitor efforts to improve stratification. So we receive feedback on our health equity analyses. Several advisory committee members expressed concern with the limited health equity data for payers and physician organizations and noted problems with individual level demographic data. Advisory committee members also recommended stratifying more measures. So in response, we will monitor efforts to improve demographic data collection and measure stratification. However, there are limitations and gaps in demographic data collection and reporting. So as illustrated by the image on this slide on the right from a healthcare payments data program report, an HPD report, there's incomplete data capture for race, ethnicity, and language. We want to note, related to this figure on the slide, that CMS does not submit ethnicity or language data to the HPD program for Medicare fee-for-service. So we've listed on the slide a few underlying key reasons why demographic data is not captured, incomplete, and/or it's challenging to compare across different data sources. These include that demographic data is not collected, that non-standard data collection, that there's non-standard data collection and reporting, that data quality cannot be confirmed, that there are privacy concerns, cultural sensitivities, and that many opt out of self-reported data. So we want to highlight that many state departments are working to encourage, require, and or incentivize health plans to have more complete demographic data, and we hope this will help improve the data available for health equity analyses. OCA will collaborate across HCI and with sibling state departments to reinforce and support these efforts. Next slide, please. So on this slide, we provide an overview of OCA's recommendation with regard to adding hospital safety measures to our measure set. At this time, we recommend against adding additional hospital safety measures, such as healthcare-associated infections and adverse events. In our view, the HCI Hospital Equity Measures Reporting Program measure set, which we propose to adopt, includes the best available outcome measures and patient-reported outcome measures, and several of the measures are also indicators of patient safety. For hospitals, these are the key measures for OCA to track to promote high quality and more equitable care and to monitor changes in quality and equity as healthcare entities work to meet the spending target. Next slide, please. So in this slide, we go into a little bit more detail about healthcare-associated infections in particular. So OCA will focus on the HCI Hospital Equity Measures Reporting Program measure set initially, and as HCI expands data collection for hospitals, OCA can reconsider adding healthcare-associated infection measures. In the meantime, OCA can reference the work of partner organizations tracking healthcare-associated infections, including CMS's Hospital Inpatient Quality Reporting Program and public reporting on CMS's Care Compare website, the Center for Disease Control and Prevention's National Healthcare Safety Network, the Department of Healthcare Services Quality Incentive Pool Program, and the California Department of Public Health's work to track and provide technical assistance to hospitals to reduce healthcare-associated infections. Next slide, please. And then with regard to adverse events, since reports and investigations of adverse events, such as surgical error, are not standard measures of quality and equity, OCA does not plan to add them to its measure set at this time. However, OCA can reference the California Department of Public Health's tracking and investigations of adverse events pursuant to Senate Bill 1301. Okay. In the next few slides, we'll summarize all of the feedback we've heard to date and OCA's responses to this feedback now that we've covered some of the major themes. Next slide, please. Okay, so this slide summarizes what we covered earlier. The major theme of feedback from the advisory committee and the board focused on adding measures to the proposed measure set. So the board and advisory committee encouraged OCA to add measures if possible, including more specialty care outcome and patient-reported outcome measures, actionable patient experience information, more access measures, including timeliness of getting needed care, more behavioral health measures, especially behavioral health outcome measures, cultural and linguistic appropriateness of care measures, structural measures, including SDOH screening for payers and physician organizations, and hospital safety measures. And then OCA's responses include that OCA will monitor new measures under development. There are nationwide limitations in measures available for programmatic use, and the timeline of measure development from conceptualization to implementation is resource intensive and can take many years. OCA is required by statute to regularly review and update its measure set over time. So the initial measure set is a starting point and can be updated over time. For example, including more measures as they become available for programmatic use. OCA recommends against adding additional hospital safety measures. The HCI Hospital Equity Measures Reporting Program measure set includes the best available outcome measures and patient-reported outcome measures and includes some patient safety measures. Next slide, please. So this slide covers feedback around limitations that we heard in our responses. So several advisory committee members noted the need to continue working to remedy missing demographic data. The AC and the board had concerns that quality measures are limited in what quality of care and health outcomes they can capture. An AC member noted that providers with more resources may be able to game quality measures. An AC member noted concerns that some physician organizations are not included in the OPA healthcare quality report cards. And then OCA's responses include that OCA will support and monitor statewide efforts to collect more complete demographic data and outcome measure initiatives. OCA plans to look at the overlap of physician organizations reported through THCE and those in the OPA healthcare quality report cards. Depending on the results of this analysis, OCA will collaborate with OPA and IHA to explore how to better align physician organizations included in the THCE data and OPA healthcare quality report cards. One challenge is that there is currently no standard definition nor comprehensive list of physician organizations in California. Next slide, please. So on this slide, we look at feedback that we received related to the theme of stratification. So several AC members had concerns with the limited health equity data for payers and physician organizations and noted problems with individual level demographic data. AC members recommended stratifying more measures, including by race, ethnicity, age, disability status, and geographic region, especially for physician organizations. A board member questioned if the DMHC demographic data metric includes age. An AC member asked if OCA can look at performance on depression screening and follow-up for adolescents and adults separately for adolescents and adults. A board member asked what OCA's and HCI's plans are regarding implementing the new race and ethnicity categories that OMB released earlier this year. And then in terms of OCA's responses, OCA will monitor efforts to improve demographic data and stratify more measures, especially for physician organizations. OCA will collaborate with OPA and IHA to explore opportunities to publicly report stratified measures. The DMHC demographic data metric does not include age, and DMHC will not be collecting the depression screening and follow-up for adolescents and adults measure broken down by age groups. HCI is working to adopt changes to the race and ethnicity categories, including combining race and ethnicity and adding the new Middle Eastern or North African categorization, though it will take time. There will be a mapping process to map data based on the old race and ethnicity categories with the new categories. Next slide, please. Okay, so this is our last slide summarizing feedback, and this slide focuses on the theme of reporting and enforcement. Several AC members pushed to focus on OCA's purpose and report information that is easily understandable, meaningful, and actionable, and suggested grouping measures, for example, preventive care measures, and highlighting subgroups, for example, older adults and people with disabilities. AC members suggested reporting on the National Committee for Quality Assurance's Health Equity Accreditation, and the board asked what OCA can do if a healthcare entity meets the spending growth target but is performing poorly on quality and equity. In terms of OCA's responses, OCA welcomes specific recommendations of measures to monitor and is committed to public reporting that is clear, meaningful, and actionable. OCA will consider reporting which payers have achieved NCQA Health Equity Accreditation and NCQA Health Equity Plus accreditation. OCA does not have enforcement authority for performance on the measure set, but will publicly report performance on the measure set and flag decreases in quality and equity in its annual reports, including for those entities that meet the spending growth target. In addition, statute allows OCA to investigate where data indicates adverse impacts on cost, access, equity, or quality from consolidation or market power. Okay, next slide, please. That's our last. Okay. All right. Again, we are collecting public comments for the next 30 days on our proposed OCA quality and equity measure set. We'll come back to the advisory committee in March and to the board in April with a summary of public comments and any revisions to the proposal. We're interested to hear your feedback on the proposal.
So before moving to public comment, we will look to this committee for any questions or comments, and we'll start on there. Go ahead, David.
Just a comment on the health equity issue. You talked about monitoring physician organizations' efforts here. At Hill Physicians, we've been trying to collect race ethnicity information, and unfortunately, prefer not to state is the most common response we get. And we can't make it mandatory. You have to make it voluntary. So just be aware as you look at this. We want to do the same thing, but unfortunately, I think the very people who are probably most likely being discriminated against are those that prefer not to state in these surveys what their ethnicity is. So it's a dilemma. I don't have an answer.
Thank you. We'll go to Sarah, then Stephen, then Karen.
In terms of quality measures, I'm wondering if something like, I think I've mentioned before, the locus or the Cal locus, which is, a standard of care in the behavioral health field, or ASAM, for example, if that could be used as a quality measure. I mean, it's a standard of care, it's research validated, and it would comparing what, maybe comparing how the patient's treatment plan correlates to the level of care that they score on these measures. Like, for example, I just noted down like level 2 low intensity community-based services. That's one of the scores. And the locus, up to 3 hours per week, not less than 1 hour every other week. In my experience, I've probably seen a lot of people who qualify at least for this, but aren't getting that frequency. So I think that would kind of highlight, well, people aren't getting the standard of care in terms of behavioral health treatment, or people are getting the standard of care. But I don't know if that's counts as a quality measure. And then also, I think you had mentioned timeliness, and maybe I already made a comment about this, but I know the DMHC and DHCS has to collect certain timeliness data, and again, would that be an appropriate quality measure? Like, are people getting timely care? And if they're not, then that indicates then quality needs to improve. And a question about the depression screening and follow-up. What exactly does it measure? Does it measure people who score a certain score on these measures, like I don't know if it's the PHQ-9 or what it is, that they get an initial follow-up mental health appointment, or like I'm not sure what that measure exactly is. And then just working at Solano County Behavioral Health, where we do collect race, ethnicity, language data, there is a declined estate option, and probably the minority of people choose that. And I was kind of impressed by the stats that nearly or at 100% of the time does Medi-Cal collect that information. So I'm thinking if we could do it in Medi-Cal, it makes sense that it could happen in commercial too, but that's just my perspective.
Thank you. Going to Stephen and then Karen.
Yeah, thank you. Yes. So regarding patient safety, a couple of suggestions may be worth pursuing. First of all, I'm not sure what it means can reference. We can talk about that, but one of the references is to the CMS Hospital Inpatient Quality Reporting Program, and that includes, I think, all the data that's available on Hospital Compare. And as you probably know, they have a number of patient safety indicators there that are easily accessible, no administrative burden for hospitals that can be used. And I think they might be helpful for the board to consider, because the list that is indicated, I think it's slide 85, if one wants to go back to that, really does not have indicators of safety except for one. So readmissions, 30-day readmissions is not necessarily a safety measure. It could be a lot of reasons for readmission. Even pneumonia rate is not so much a safety indicator as a quality of care indicator. Pneumonia could have been pre-hospital, not due to anything the hospital did in the way of safety. The one on treatable complications is a safety measure. So there's maybe one measure among the whole set. So I'd encourage the board and staff to kind of revisit some of the existing data sets that could be used to add a safety measure. A second area that can be explored as well is Leapfrog. Leapfrog is a private organization in which hospitals voluntarily submit patient safety data. It now includes over 3,000 hospitals. In California, 280 of the approximate 400 hospitals in California that we saw earlier, nearly 70%, participate in Leapfrog's patient safety grade program. And what Leapfrog does is it takes these data, many of it come from the patient safety indicators that ARC uses and CMS uses, and they aggregate that into grades A through F, A, B, C, D, E, F. And so we have 70% of our hospitals now already reporting on that. And just to flesh it out, 128 of those, 46%, actually receive an A grade. And for the first time, that puts California in the top 10 of states in the country with hospitals in an A grade of patient safety. The leaders, by the way, if you're interested, are Utah, Virginia, and Connecticut are 1, 2, and 3. California is now number 6. So that would be another way to go. And what one could do with the 30% that don't report is just exclude them the first year. They're probably smaller, rural, maybe don't have the surveillance technology. I'm talking about just hospital-acquired infections, not necessarily falls or other kinds of events or medication errors, just hospital-acquired infections. And I think some of the smaller hospitals and rural hospitals will also be coming aboard as well. So I really think that should be reconsidered to get a meaningful measure of patient safety on the list, and those would be a couple sources.
Thank you.
Thanks for that. Yeah, so in terms of the CMS Hospital Inpatient Quality Reporting Program, we were looking at that organization as one of quite a few that are pretty closely tracking and publicly reporting the healthcare associated infections, including the 5 or maybe 6 that the California Department of Public Health really closely tracks and publicly reports on and provides technical assistance around. And so we were really looking at the CMS Hospital Inpatient Quality Reporting Program as a resource for us on healthcare associated infections measures in particular. And the thinking was that there are quite a few organizations, including on the CMS side and the CDC, Center for Disease Control and Prevention side nationally and within California, CDPH, really closely tracking these. And so there's not necessarily a need right at this time for us to include them in our proposed quality and equity measure set, though it's something we can consider revisiting over time. And that they're also the tracking and public reporting on the healthcare associated infections measures that's being done by all these other groups. The OCA can draw on that and look at that, and even though it's outside of our proposed measure set. So it's a little bit on the hospital safety measures in particular. Sorry, go ahead.
And I'd just add to, in terms of the details and how we're thinking about, we can reference the hospital safety measures, is that we are within a performance improvement plan. We don't only have to look at the OCA quality and equity measure set. We can look at other measures of quality and equity in addition to the OCA quality and equity measure set in approving or disapproving a performance improvement plan. So that's the detail there a bit in terms of how we can reference and potentially include other measures of quality and equity in considering a performance improvement plan.
Just to add, thank you. I mean, that's helpful, but
Use the
that's
mic.
true for a number. Yeah, that's true for a number of these measures here as well. I mean, they come from different sources, right? And they've been blessed by these groups, and they're on the list now. So some people may have a hard time understanding the difference between just referencing something that's readily available and why you wouldn't necessarily add it to the list. If it doesn't require, administrative burden or reporting on the part of hospitals or others.
Yeah, I think we're just here thinking about a lot of different things in terms of balancing how we approach the quality and equity measure set and using, fully adopting the HCI Hospital Equity Measures Program and relying on that and really aligning there versus adding additional measures into OCA's proposed quality and equity measures that are not already included in the HCI Hospital Equity Measures Program, and really leveraging the discussion and the work that they did in that program.
Will there be, just one more question, follow-up, will there be feedback then to HCAI on encouraging them to, in the future, to draw on those measures? Just because they're not listing them now, and therefore you feel you cannot, or the board feels it cannot use them?
Yeah, hi, sorry for being late. We went through a pretty rigorous stakeholder process, and HCI did in adopting the hospital equity measures. So it was a requirement. It was a program set up by legislation, and we have had an advisory committee. So I think there will be a revisiting of it. But just to know that that did happen over the course of, I think, about 2 years.
Right, but one can add to this. You're not bound by just this. You're
Correct.
starting with this. Okay. So I guess the question some people may have around patient safety is, well, why not, add one? It doesn't necessarily compromise HCI's, in the future, hopefully they will be including those kinds of measures. And the new information, and maybe you're aware of it, is around leapfrog. In fact, the majority of California hospitals participate in that, and that would be another thing to feed in at some point. Thank you.
Thank you, Karen, and then Carolyn.
Actually, sort of a ditto on the patient safety. I had a similar line of thinking because all of these are things that are being published elsewhere. So I'm not totally understanding why we would not pull over some more specific patient safety, particularly the hospital-acquired infections, where we know what the impact is on cost, which is up, and on outcomes, which is down, right? And so it would seem to be a really important piece to be closely tied to OCA's efforts. And I think the comment on leapfrog is a good one too. The grades are easy to follow, and you would see, for example, that UC Davis got a D and also shows up in your high cost hospitals, right? Which maybe would mean that's a place to put some emphasis and focus. My other comment is on the physician organizations, the OPA. So while it's true that OPA is not including the demographic stratification, some of those actual measures are HEDIS measures for which NCQA does have stratification. So can we at least require physician organizations to provide that data on demographics where they have it, where they're already required to track it for those measures, so that we don't just ignore equity entirely for the physician organizations?
Thank you. We'll go to Carolyn. Oh, go ahead.
Yeah, thanks for that flag, Karen. We can follow up with OPA to, we've had several discussions with them in terms of coordinating on the adoption of their measure set within OCA's measure set, and we can follow up specifically, but I know it is part of their work and kind of intention to add them as they're available, but maybe as David mentioned and other folks have mentioned, that it is quite complex at the physician organization level, but we'll definitely follow up.
Carolyn and then Mariel.
Thank you. I just want to make sure I'm understanding this slide properly, because on slide 78, there's those listings of statutory snapshots really that you're looking at. But then when you move deeper into this, for example, down into, I think that's slide 87, where stratification is talked about, that list of statutory, is it included in what we're looking at here? Or are we now dropping off some of those measures? I'm particularly concerned about things like dropping off of the disability picture, because, there's so much discrimination, and it's a fine line. I know we have this argument daily at our centers for independent living, where there is obvious discrimination, especially in healthcare, where individuals cannot receive care because maybe they're working with a physician or a hospital that doesn't deem the cost of that care justifiable to their individual condition. And you have the flip side of it, where you have individuals who don't want their disability to be factored in as a separation from the masses. But when we look at the cost of care, we have to stop and think, how could we not factor that in? I'm just curious if, when you get down to this slide 87 with these monitoring efforts, is disability one of those monitors, or is it pulled out of here? Because then later on in 93, somebody's saying, why don't we include disability more? So I'm a little confused as to what we're actually looking at when we get to this slide here on stratification.
Sure, so I can start and welcome Jana and others to add. So part of the challenge here that we face with stratification is that not all of these measures that we would think about stratification are collected in a standardized way or are collected at all. So the statute, from my understanding, requires us to consider a kind of wide range of demographic data factors that we could stratify measures for if they're available in a standardized way and they have been implemented. So we are working with and collaborating with others, measure stewards and measure organizations who are conducting stratification, and the focus really is on race ethnicity currently based on the available data. But we do plan to collaborate with the measure stewards of and the measure organizations of the measures we're proposing to adopt to expand as that data is available. So this is just because we're focused on the measures stratified by race, ethnicity in the current measure sets, does not mean that that is the end, that we would continue to look for other avenues of stratification that are occurring in those measure sets as they are implemented. Jana, anything you want to?
Go ahead, Mario. I appreciate this discussion. I'm wondering if this is at all related to OMB's SPD 15 and just expanding the data that we're collecting on ethnicity, race, also the addition of the MENA categories, Middle Eastern and North African, because I know that that's something that's rolling out and that states have some months to come up with a plan. But I do want to echo what David had already shared, is that, a lot of our most marginalized groups will continue to opt out of this voluntary self-reported data. And so, given that government distrust may, I don't know, persevere even more in these coming times, we've got to be practical. How are we going to do this when there's current state of affairs? And in the meanwhile, what kind of partnerships are y'all putting together to ensure that this data is collected in a way that is forthcoming by people themselves? Right? I guess what I'm saying is, how are you going to foster this trust when there's a lot of distrust right now?
Yeah, thanks. I think it's a very good question, something we're spending a lot of time thinking about. I was just on a call with the secretary, with directors, going over some of the very disturbing executive orders that have come out. And so we are very concerned about our immigrant communities and our LGBTQ plus communities. And so we have had, with the Hospital Equity Measures Committee, we did do a presentation about best practices. And you all are often your best resources is to hear from folks on the ground. My experience when I was a frontline provider like Sarah's was generally, if you ask someone in a respectful way, most people will answer and give self-identified information. Of course, you always have to have a decline to state option and have that available to folks, but most people will answer the question. And so I think it's a lot about getting out of this mindset that people won't give the information, making clear that it's voluntary, doing presentations about how to best ask it, and then frankly, just starting to publish the data. So, if commercial health plans aren't doing as good of a job as they can, partly we need to have transparency around that and bring that to light as a continued encouragement for improvement.
Yeah, I understand that, but there are going to be, again, the people who fear these repercussions the most, right, are also the people who face some of the most severe consequences anyway. And so I'm wondering, a lot of community-based organizations collect data like this, and they collect it much more easily than government agencies. Is there any kind of initiative to partner with these local agencies to standardize some kind of data collection practice so that, all of this data can be compiled? Because a lot of this data is here. It's just they're siloed.
Again, it's a good question, but I want to be clear. This is not data that is collected by government entities other than the Medi-Cal, Medicare. On the commercial side, right, we're relying on private entities. So just want to make that clarification.
Thank you. We've got Joan and then Sarah.
Regarding the infections and adverse events and the outcome measures, I appreciate the ability to reference the work that others are doing, and would encourage, as you're developing reports and aggregated information, as well as information available by hospital in particular, that to the extent you can, fold in at least takeaways and best practices, so that when we are then
in the future ready to include those outcome measures, that we will have started building it into our understanding of quality and equity. And yeah, it's not a this year, I know, but in terms of how do we set it up for the best success in the future, if it's just missing, then it'll be harder to add.
This is kind of like a side comment about collecting data, because I'm no expert on collecting data, but when I was hearing some of the comments, I was thinking about how, at least in my specific workplace, for both adults and children and adolescents, we have a section of the assessment where it's confidential information, meaning it isn't released when records are released. And oftentimes that is used for when a child or teen wants to report a sexual orientation or gender identity that they're not ready to share with parents, although there could be other things that are included in there. But it just made me think, like, if there are concerns about like safety in revealing certain information, like maybe there are ways to go about it, like even starting like that, that doesn't mean that maybe in the future the parent wouldn't be in the know because the child or teen decides it's safe and they want to try to broach that topic with the parent in a family therapy session, and eventually it is more on their official record. And that's, you know, part of the treatment process, the relationship with the treating clinician, and maybe over time some of that more information can, you know, be added to the data, but maybe there's, you know, it's not black or white. You can use some strategies to get that information, even if you can't get it or record it officially at the very outset.
Other comments? Yes, Carmen.
Kind of, you know, echoing what some other folks said, you know, it'd be great to get more safety information from hospitals, particularly because we know they exist. I guess I had kind of wanted to back up because I know there was a mention at one point about using and looking at either the measure sets or additional information in performance improvement plans, and how would that actually work? Like what does OCA envision in terms of potentially using these measures in performance improvement plans? And then I guess an overall kind of comment on the discussion is there a way that OCA can help identify, you know, missing data, best practices, whether they're best practices or whatnot? Because it sounds like part of the problem is that there aren't requirements for some of this information to be collected. So like it sounds like there may be a larger issue here with data collection requirements. So I guess two different questions, like how does OCA plan on using the information in PIPs, and then, you know, how can we help identify where there are gaps in information?
So in terms of, I guess I'll start with the overarching approach to PIPs, but would welcome Vishal and Elizabeth to weigh in. But kind of the guidance is in statute that the director can consider other measures related to quality and equity when approving or disapproving a performance improvement plan. So not just OCA's quality and equity measure set. So other factors of quality and equity can be considered in a performance improvement plan. And then additionally, the director must consider the impact on quality, equity, access, and workforce stability when approving or disapproving a performance improvement plan. So those are kind of the overarching structures of a performance improvement plan. But, you know, we as an office still have a lot to do in terms of developing the structure and the process for a performance improvement plan.
Yeah, Margareta, you covered it pretty well. Carmen, is the question more about how we're using the data just in general?
Yeah. Oh, yeah. I guess because part of the questionnaire is like, what are we using the data for? Because trying to. It sounds like a lot of people want, which I agree with, was just like we want some of this equity and quality data compiled, and I'm just wondering what is since you're looking at currently existing data, what is the value being added to compiling them in OCA? And it sounds like that might be in the PIP process, but I'm just trying to figure out like what are we doing with the data, and that might help in terms of figuring out what data to collect.
Yeah, it wouldn't just be for the PIPs, although that's very important. It's we don't want to just report on cost alone. Like we also want to have a balanced approach. So at the same time, we're trying to slow spending growth. We want to report on quality and equity so that we're showing that it's maintaining or holding steady or improving. That's a long-term goal, so that slowing healthcare spending doesn't come at the expense of lower quality. So it'll be for that purpose to kind of have that balanced scorecard. So our public reports are going to report on both spending and quality performance, and then eventually we'll add APMs and primary care spending and behavioral health.
That's helpful because it's more of the analysis of how does everything that OCA is doing impact health and equity
Yes.
Sumana and then Carolyn.
Sounds like all comments are going towards the same place of, difficult to get this data, important to do it. And just to point out that at this point and for the last few years, so much of the advanced primary care work is around these same measures. And as we look at them so far, there's no correction. It is much harder to get under, 9% A1C in somebody who's a field worker who speaks Spanish. And I keep bringing up that, I know that's what you're working to. That's our common goal, is to have, when we're talking equity and we're trying to get this is what it is, but we're already being report carded constantly without a correcting factor for what we're doing on the ground that is with very different populations.
Thank you. Maybe this is kind of a question and a comment all in one. Thinking about the public comment period and thinking about data collection, I sit and I'm the chair of a 9-county systems change coalition, and we have collected all kinds of data on these very topics. And when we go and we're doing listening sessions and we're doing one-on-one interviews throughout the state, we hear a lot, and we hear discrimination, and we hear racial prejudice, and it's rampant. My question would be, what would it take for some of that information, if it were put into public comment, for it to be considered in the broader picture? Because I have a 92-page report that I helped write about the inequities going on in Northern California, and I would just upload that puppy right up there if I felt it would make a difference, right? Because the data, I believe the data is there. So I guess my question is, what will it take for us to go a little bit deeper and actually get this information brought to the consideration table?
Thanks, Carolyn. I think it's a great question, and I just want to temper expectations a little bit about what OCA is and what it can do, right? So we're obviously, just to restate this, I mean, we're created primarily to focus on costs, but we're very focused on trying to get to a high-value system. And so the purpose, as Vishal was saying in the conversation with Carmen, the purpose of the equity and quality measures is we want to see progress, and we also want to see if, as entities are meeting the targets, hopefully we don't see a worsening of equity or quality. So the team, I think, has done a very thorough look at possible measures, and we can't be all things to all people. So the effort you're doing is really critical, and we need to we are trying to have a broad impact, and also, Margaret and Jana have small and mighty teams that are just limited. So I'm not going to tell you to not upload your 92-page report if it has great information in there. We are very carefully considering all of the public comment that's submitted to us. And so if you think it makes has a meaningful story to tell of what our scope is, then please, we look forward to reviewing that.
And please, no disrespect to the work that's been done, because, we're another small and mighty team, just on a different scale. And we're all doing what we can to put in these effective change. And so it's puzzling sometimes to understand, how do we bridge some of these conversations, because the same people that are suffering the inequities are also some of those very same people who can't even afford to go to the doctor because the primary care is 3 hours away and they don't have transportation or the money to afford the gas for the vehicle when they do have the transportation. So it kind of all folds in. And that's where my brain went, is, how do we get a more holistic snapshot so that perhaps we bring those bigger decisions where they require to be. But hey, absolutely no disrespect to the small and mighty, right?
Thank you. Other comments or questions from committee members? Also noting we have committee members attending virtually, monitoring for any questions and comments from them. Yeah, Mariel.
I think there's a lot of consideration that we have to do with what data is valuable and how we've been using it. I think we've really prioritized quantitative data, and while that's great for generalizing, I think what we're also getting to, and part of your 92-page report, is all of the qualitative data that gets missed when we don't collect it with this kind of stuff. But I'm not saying, it's up to these agencies to collect all of that. But I think, right, as we're moving into the realization that storytelling is much more important than we had given it credit, how we think about data should also expand as far as how we collect it and how we actually utilize it and share it with communities.
Thank you. Other comments or questions from committee members? Seeing none at this time, I think that takes us to public comment on this item. Please step to the podium, or if you're attending virtually, please raise your hand.
Thank you for giving me an opportunity to quote Aaron Wildowski, who founded the Goldman School long before it was called the Goldman School. The plural of anecdotes is data, and so it does matter. A couple of points on the quality and equity measures. We too think the health acquired infection measures are important and should be included. It is the classic example, as Karen said, of failing the triple aim. It's high cost, bad care, and it's correlated with inequities as well. Simply using it sometimes in the performance improvement plans or the other enforcement efforts seems to us problematic for other reasons. And so we also, we have been surprised at the hospitals that are allegedly high quality that score poorly on this. This is also an area where the state of California has made very substantial improvements, actually reducing infections and being able to take some of the infections off the list. So we think, unlike many of the other quality measures where 30 years later we haven't actually made improvement, this is one where we have, so it seems a shame to not include it in this work and to recognize, as the law does, that that OCA is supposed to look at the question of quality and equity. With regard to stratification by various demographic measures, the two things that almost everybody in the healthcare system knows, whether it's a payer or a provider, is age and disability. Disability is slightly less perfectly, but age is always a factor that's available, to whether it's to the health plan or the insurer or the doctor or the hospital. So to not stratify by large age categories like children, adolescents, and adults and seniors seems to us another missed opportunity. Similarly, we understand the emphasis on race, ethnicity, and language. It's very important. Disability status is equally important, and I think it reflects that earlier disability was more focused on. So we also think that's an important area of stratification. And yes, we recognize OCA is not all things to all people, but you also work with sister agencies and with those who are developing the measure sets to push on this. Thank you.
Thank you. Additional public comment? Looking virtually, seeing no hands raised, noting for the record we have about 63 virtual attendees. Looking in the room, seeing no one at the podium. That concludes public comment on this item and takes us to our afternoon break. I believe we're going to take a 15-minute break. It is 2:44 right now. We'll resume at 3 o'clock. All right, let's reconvene. If we have everybody back, we'll go ahead and move to the next item. We're on item 7 now. It's the update on the behavioral health benchmark. I will turn it back over to Margareta Brandt.
Good afternoon. So today we'll wrap up our agenda with an update on the behavioral health investment workstream, and in particular our proposed approach to a focused benchmark for behavioral health investment. So I will cover the next few slides again to introduce us, and then I will turn it over to Debbie Lindis to walk us through the rest of the presentation. So as always, starting with a reminder of statute. So here for behavioral health investment, as with primary care, OCA statute requires us both to measure the percentage of total healthcare expenditures that go towards behavioral health care and to set a benchmark for behavioral health spending that sustains infrastructure and capacity and shifts resources from specialty care towards supporting and facilitating innovation and care improvement. And then moving to the next slide. So before going into the details of our proposed approach to the behavioral health investment benchmark, I wanted to review a few key important points about our proposed approach to measuring total behavioral health spending. So if we could go to the next slide. So I think you all have seen this graphic before, but just this graphic shows the components of behavioral health spending that could be included in states' measurements of behavioral health. So spending data here can come from several sources, including patients' out-of-pocket spending, state budget appropriations, and spending for social services that support individuals with mental health and substance use disorder conditions. And for OCA to fulfill our statutory mandate, OCA is focused on those services that are part of total healthcare expenditures. So the subset of behavioral health spending that is part of total healthcare expenditures. So the clinical services paid for by public and private payers through claims and non-claims payments. So that's pulled out there in that darker blue quarter of the circle. So we'll start, and we propose to start with a focus on commercial and Medicare Advantage payers, similar to how we've approached the measurement for THC, and then to add Medi-Cal health plans to our data collection later. So that we're proposing to follow that process, and eventually we'll add Medi-Cal behavioral health spending as we work with DHCS to understand and incorporate Medi-Cal's behavioral health spending into our approach. And we recognize that this is a relatively narrow view of behavioral health spending, and in the future, OCA will explore the possibility of using supplemental data sources to capture some of the other spending that's acknowledged on the slide. So we in particular want to acknowledge the significant direct spending by consumers on behavioral health services. And while our current data sources may not be able to quantify the spending, we are studying out-of-pocket, out-of-plan, or self-pay spending for behavioral health as part of a separate work stream. And we are collaborating with that team and incorporating the insights that they learn from that work into our work moving forward. So that is work still to be coming and to be shared eventually once it's ready. So if we can move to the next slide. So this diagram shows how behavioral health spend is generally determined across states that are measuring behavioral health spend and other organizations that have measured behavioral health spending. It's generally determined by decisions about the diagnoses, the care settings, the providers, and the services and treatments that are included in a definition of what is behavioral health spending. So we are working with the investment and payment work group on specifications for our proposed spending definition, and we'll update you on that aspect of our work the next time we meet. And then going to the next slide. So again, this should look familiar as it's familiar. It's the equation we've used for primary care and adapted it for behavioral health. So this is the general equation we're looking at for guiding our behavioral health investment measurement, which is the numerator here. So OCA statute requires us to measure behavioral health spending as a percentage of total medical expenses, which is the denominator. So both the numerator and the denominator have a claims and non-claims component because the data for measuring them is different. And as you'll see in the note here, the numerator will include patient out-of-pocket responsibility for behavioral health services obtained through the plan. So essentially services for which a claim or encounter was generated. And the denominator will include pharmacy spending and all patient out-of-pocket responsibility for services obtained through the plan. If we can move to the next slide. So as with primary care, as you can see, we're adopting most of our work for primary care due to behavioral health, but do recognize the complexity and the additional lenses that we're taking for behavioral health spending. So as with primary care, we are proposing to measure behavioral health spending using 3 modules. So spending via claims, spending via non-claims through methods such as capitation, and a 3rd module, behavioral health in primary care, which will include both claims and non-claims spending. So we define this behavioral health and primary care module in our work measuring primary care spending and may adjust it over the course of our behavioral health work. So in upcoming meetings with the investment and payment work group, we're looking to dive into more details on the behavioral health and primary care module. And so OCA will be able to include spending from the module in either primary care or behavioral health spending measurements, and we'll also be able to analyze it separately to inform policy discussions. So with this background on kind of our approach to measurement and the data collection and measurement scope, I'll turn it over to my colleague Debbie Lindes, Healthcare Delivery System Group Manager, to give you an update on our work to develop a framework for behavioral health investment, for a behavioral health investment benchmark.
Good afternoon, and thanks, Margareta, for that introduction. I think, can you hear me? Is this okay? Volume? Okay. Great. So I'll start our discussion of the behavioral health benchmark framework by highlighting that OCA is proposing to make a distinction between our approach to measuring total behavioral health spending, which will be broad, and our approach to the investment benchmark, which can be focused to measure a portion of overall behavioral health spending that reflects policy goals. This approach is illustrated on the slide with the lighter blue circle showing how the proposed benchmark data will be a subset of the data used to measure total behavioral health spending. Next slide. So more specifically, OCA's current straw model proposal is that the benchmark should promote behavioral health investment that helps individuals receive more timely, high quality, and culturally responsive care in more appropriate settings and with less out-of-pocket spending. This would be achieved by improved access to outpatient and community-based services that are in-network. To support achieving this purpose, the benchmark would be structured to include covered, in-network, outpatient, and community-based behavioral health services. And for example, community-based services could include things like mobile clinics and supportive services that are delivered outside of traditional healthcare settings. We are considering excluding pharmaceutical spending from the benchmark, though we will be discussing that further. This proposal was developed with input from the Investment and Payment Work Group, and OCA will continue to refine its proposal based on feedback from this group and the board and through further discussions with the work group. Next slide. So here's an illustration of the relationship between the scope of measuring total behavioral health spending and measuring spending against a focused benchmark. The benchmark, the inner light blue circle, might focus on community-based and outpatient care settings such as mobile clinic services, outpatient facility, and professional care, including primary care and telehealth services. The service categories for the benchmark are a subset of those used for overall measurement. In addition to the benchmark categories that are highlighted in light blue, the total spending measurement would include categories such as emergency department and observation services, residential services, long-term care, and inpatient services, which are represented by the darker blue outer circle. Next slide. So our straw model proposes that the benchmark promote more timely, high quality, and culturally responsive care in more appropriate settings and with less out-of-pocket spending. So the proposed benchmark framework supports these goals because, first of all, the focus on outpatient and community-based care both emphasizes prevention and population health and incentivizes increased access to timely and high-quality upstream care, which should reduce the demand for higher intensity settings. And this focus aligns with other state policies such as Senate Bill 855 and Senate Bill 221 that address access and parity, and it complements Proposition 1's investments in the expansion of infrastructure for facility-based services. And I'll share more details about the alignment with those policies in just a minute. The focus benchmark would help address California's access and capacity gaps that are exemplified by the data points on the slide regarding the unfortunate current state of availability of services for adults and adolescents and the timeliness of care. Next slide. Payers' behavioral health networks are lacking to the extent that more than half of Californians find it difficult to find in-network providers, and they use out-of-network providers 15 times more frequently for psychiatrists and psychologists than for medical and surgical specialists. A benchmark focused on in-network spending could incentivize expansion of planned networks, which is also consistent with the goals of SB 855 and SB 221. Improved access to community-based and outpatient care could also mean more culturally responsive care. Anecdotal reports from stakeholders suggest this is needed, as does survey data that reports only a third of Latino, Asian, Native Hawaiian, and Pacific Islander Californians agreeing that their communities have mental health workers who have knowledge about their needs. Next slide. So it's important that OCA's approach to measurement and benchmarking aligns with or complements other behavioral health policies in California. These next few slides review some important recent policies. And of course, there are other policies that we didn't include here. But with the benchmark straw model in mind, we'll look at a few of those major policies, starting with Proposition 1. So one part of Prop 1 is the Behavioral Health Services Act. This new law reforms the Mental Health Services Act of 2004 and realigns behavioral health funding by increasing access to community-based care, particularly for high-need populations, such as those experiencing houselessness or who are involved with the justice system. A benchmark focused on community-based services could incentivize payers to increase investment in such services where these individuals live. The second piece of Prop 1 is the Behavioral Health Infrastructure Bond Act, which authorizes $6.4 billion in bonds to finance behavioral health treatment beds, supportive housing, community sites, and housing for veterans with behavioral health needs. A benchmark focused on community-based care would complement Proposition 1 investments and incentivize investment to additional areas of need to support local behavioral health infrastructure. Next slide. So another important, relatively new behavioral health policy is SB 855, which was passed in 2020, and which addresses parity for behavioral health services. SB 855 requires insurers to cover medically necessary treatment for all mental health and substance use disorders. To align, OCA will use diagnosis codes to differentiate between mental health and substance use disorders for a broad set of behavioral health conditions and services. SB 855 also mandates coverage for out-of-network mental health and substance use disorder services when in-network access is not available within geographic and timely access standards. It prohibits plans from denying medically necessary services on the basis that they should or could be covered by a public entitlement program. Our focus for the benchmark on in-network care covered by commercial and Medicare Advantage plans aligns with the goals of these provisions. Next slide. So SB 221, which passed in 2021 and became effective in 2022, ensures that appointments with non-physician mental health and substance use disorder providers are subject to timely access requirements. It requires that an enrollee undergoing a course of treatment for an ongoing mental health or substance use disorder condition can get a follow-up appointment within 10 business days. Additionally, if a plan operates in an area with a shortage of providers and is not able to meet the geographic and timely access standards with an in-network provider, the law requires the plan to arrange coverage outside its contracted network. And as I noted in the previous slide, this is also a provision of SB 855. OCA has the opportunity to align with SB 221 by setting a benchmark focused on in-network, outpatient, and community-based services that would encourage increased investment in and access to those services, while SB 221 holds health plans accountable for non-compliance with those timely access requirements. And in addition to the focused benchmark, OCA could complement SB 221 with potential analyses using data from the Healthcare Payments Data Program that leverage OCA's behavioral health measurement definition. Potential analyses could include looking at quality measures related to behavioral health care and follow-up, the number and distribution of providers and facilities billing for behavioral health services, and licensed providers in payer networks as a percentage of total licensed providers in California. Next slide. OCA has been working with the Investment and Payment Work Group towards a proposal for the behavioral health measurement definition and benchmark approach since last July. And we'll share with you next some recent feedback we've received from both the Healthcare Affordability Board and the work group. In December, we provided an overview of our progress to the Healthcare Affordability Board. And we heard from the board support for a focused benchmark approach and interest in shaping the benchmark to support statewide goals. Board members emphasized the importance of future incorporation of Medi-Cal measurement and of collaboration with other ongoing efforts, including those measuring out-of-plan spending. Board members also talked about aligning OCA's policies with other care transformation efforts in California, like those we've just reviewed. Next slide. So this slide summarizes the feedback we've heard from the work group. From that group, we've heard that overall there's strong support for the benchmark straw model, although a few members have raised questions or concerns about the benchmark excluding spending in inpatient, long-term care, and residential settings. There's interest in the benchmark aligning with Proposition 1, SB 855, and SB 221. There's strong support for including autism and other developmental disorders in claims-based behavioral health measurement. Autism is one of the diagnoses that have not been unanimously included in the definition by the 3 other states that currently measure behavioral health spending across the full care continuum. 2 other such diagnoses are dementia and the adverse effects of self-harm. There's mixed support in the work group for including the medical services related to dementia and adverse effects of self-harm, and stronger support for including the behavioral health treatments related to those diagnosis categories. We've also heard that work group members favor including a broad set of diagnoses in our definition and a wide but more focused list of services for behavioral health treatments. And several members have suggested using California's parity laws to guide what conditions and services are included in the definition. At last week's workgroup meeting, we also heard strong support for including behavioral health screenings and assessments in OCA's spending measurement. Next and final slide. So here's our tentative timeline for the behavioral health work, which has been changed slightly since the last time you saw this. So we presented an overview of the behavioral health work stream to the board in December, and we plan to meet with the work group monthly from February through July. We've extended the timeline by 2 months to allow more time for the work group to develop its recommendations and for the advisory committee to have a chance to consider them at both your March and June meetings. OCA now plans to take a recommended behavioral health investment benchmark to the board for approval in July. We'll provide interim updates and gather feedback from you in March and June and from the board at their February, April, and June meetings. And thank you for sticking with this presentation so late in the afternoon, although not quite as late as we thought it might be at this point. So now we'll open it up for your feedback and questions, and we're especially interested in your input on the proposed approach to the behavioral health investment benchmark and the straw model we've proposed. Thank you.
All right, looking for questions and comments from the committee. We'll start with Sam.
Hi, thank you so much for your work on this and for walking through this. I would encourage inclusion in patient care as part of the benchmark to be consistent with Proposition 1. And one of the allowable, uses of Prop 1, the BCHIP bond funds, is to develop or renovate facilities that include inpatient acute care beds. And that's something, and I know that while we all would prefer that folks get care in the community setting, there are still folks that need that inpatient care for, a short time. And right now there are, a shortage of those beds across the state too. And it's the shortage is particularly acute in some other areas. And so I think that Prop 1, recognizes that and makes that, an allowable funding purpose. And there's a whole RFP process, right, to prioritize and fund those projects that are most needed in the state. But I would encourage that OCA, align with that and include the inpatient services as part of the benchmark.
Thank you. I've got Samana and then Sarah.
100% in support, of course, of all of this, and can't wait to see it become reality. And I've mentioned to a few of you that after decades, here I have identified a local, bilingual, bicultural therapist who wants to join my practice, and I can't do it. I've been talking to state and national experts to figure out how to get this going right away, because I thought that was going to be the problem. But in fact, insurances don't want to bring her onto their networks. I am not 100% sure if that's what's going on, but it looks to me like one particular large VC-funded online player has become the answer to Anthem, Blue Shield, and everyone else's network issues for therapy. And, I can't get this done. So I just want to bring this up as a little anecdote because it's something I'm so excited about, she's so excited about. It will strengthen the quality of the care we can both provide. But it's not happening. So I want you to just be aware that in this broad range of offerings that you foresee, there's a lot right now. It helps me understand why the networks are so lacking.
Thank you. Sarah?
I think that experience you're talking about is not unusual. A big barrier for therapists in private practice is getting into networks. I know I was going to say something more about that, but I forgot because I was thinking about, I originally was going to state, I have a different view about adding hospitalizations in that, in my view, Prop 1 really focuses on the level of care when somebody's rights are taken away, and we want to do everything in our power to prevent that, to give people the treatment they need to not have to get to that point or meet 5150 criteria. And in my mind, I probably said this before, it's very similar to we'll wait until your cancer is stage 4 before we provide treatment. not giving people, and it's a social justice and equity issue because the people with means can pay out of pocket for the lower levels of care, not giving people the humanity of lower levels of care to prevent being in a position where their rights are being taken away and they're in involuntary treatment is just, I mean, that's what the state has chosen to present and to focus on, and they have, you know, reasons for that. But like I see in my workplace, so Medi-Cal, county behavioral health, people are on wait lists for almost a year for individual therapy. And that is completely unacceptable. It's like denying people maybe 1 out of every 3 of their insulin injections. I mean, we're not giving people a chance. And these are people who, a lot of the clients who come in are homeless. They are having problems with substance use. And so we're funneling people into this situation where their treatment option is that highest level of care. And so focusing the benchmark on those lower levels of care, I think, is really the humane thing to do.
Thank you. Karen?
I completely agree with Sarah's comments. I'm very glad to see the proposal that has this specific focus on the outpatient community-based services. I think that is where the investment is needed. And if you were to include the inpatient hospital care, it's very, very, very easy to spend a lot of money paying for that without getting much in the way of outcomes, as we saw when we looked at the hospital operating margins earlier in the psychiatric hospitals. So I very much support the staff's recommendation and the work of the work group. One comment that I have is just to have you thought about how you will look at whether the benchmark is overall meeting goals about better, more accessible care, because I think that is there with the primary care benchmark through your quality measures because they're so strong on primary care. So you'll be able to see, right, we instituted this benchmark and maybe here's some trends in the quality measures. It's not clear to me that you have the same thing on behavioral health, which there's a problem in behavioral health quality measurement in general. We know that, so I understand why it's like that, but I don't know if you would have the authority, but I feel like it would be useful to at the same time as you're instituting a benchmark, look at things like networks and are they getting stronger? Is there more provider participation in networks? Particularly for the outpatient services, or are we reducing out-of-pocket, particularly out-of-plan spending, which I know is difficult to measure, but to the extent there is some data on that, is there a way to pull that in as you institute the benchmark just to see what impact potentially there is from this work?
Sure, so I can start. And we, in the investment and payment work group, we've talked a lot about, and I'm probably going to miss a lot from our list that we've brainstormed about how we could use the healthcare payments database to complement our work measuring behavioral health spending and setting a behavioral health investment benchmark. So we have a long list, and I'm blanking on what's all included, but essentially thinking about how we could use the HPD data to complement our work here, and also looking at data from DMHC on, they are doing lots of work on behavioral health and have several behavioral health investigations. So thinking about how we can incorporate some of those factors to look at those in, collaboration with the behavioral health spending and investment benchmark.
Sarah?
Going back to quality measures, because the state of behavioral health care is so poor, that's one reason why I keep thinking these research validated measures that tell you or give recommendations on standard of care, like HAL-LOCUS, recovery and needs level, ASAM, and matching to see if people, are they receiving that level of care or not. I mean, that's very basic, but that may be, in my mind, a sensical way of measuring quality. Are people even getting, the standard of care in the field? Kind of, are people getting the appropriate medication to treat their diabetes. That's very standard, but we might be at that level with the way our behavioral health care system is. And the out-of-network care, I mean, that is the law now. In my experience, the main way that patients can avail themselves of that by law required coverage is filing a grievance. So I'm not sure if health plans do have a plan in place to deal with situations when there isn't in-network care. How do they seamlessly provide the out-of-network care? Just in my experience as an employee, and so I'm not, knowledgeable about all of the ins and outs of running these facilities, but at Kaiser Napa Solano Psychiatry and Solano County Behavioral Health, there is no official program to address out-of-network except for filing a grievance. And that's what I have helped supported some clients in doing. And so even just seeing our plans, do they have a plan to address this part of the law that is required of them? And that is, it's inevitable. People aren't going to have timely in-network care. So does a plan even exist for people to access out-of-network care besides filing a grievance? So again, like basic checks to quality, like does a plan even exist to help people with this, access this care? And then, oh gosh, it slipped out of my mind again, the thing about out-of-network. But if it comes back, I'll raise my hand.
Thanks, Sarah. So we can follow up with the DMHC to ask kind of more questions about how they're implementing and assessing performance, but in terms of having access to out-of-network care when in-network care is not available.
I do know while I was at Kaiser, their DMHC was doing a special investigation, and after I'd left, they came out with that $200 million settlement, I think a $50 million fine and a $150 million corrective action plan. And to my knowledge, the correction action plan, which is supposed to be, I think, agreed upon by DMHC and Kaiser, has not yet been agreed upon. So that, I guess that's one of my criticisms is, there's these laws on the books, which are great, but unless they're enforced in a timely way or corrective action plans don't take years to develop, it's hard to reap the benefits of the laws.
Thanks, appreciate that. And I had a follow-up question about the standard of care measures, just wondering how, whether those are collected and how they're reported, and, would welcome suggestions for how we might incorporate those.
So, I guess I'm also excited for you guys to finally incorporate or eventually incorporate Medi-Cal data. That is like, for example, at my current job, we use the recovery and needs level assessment tool, and we use that for every client at every assessment. And then there's different measures every 6 months that the treating clinicians use, and that's not unusual for Medi-Cal and county. And for children, we're using the CANS. That's not traditionally, well, it's somewhat of a level of care tool, but the creators of, it's the Child and Adolescent Needs and Strengths, is creating a specific level of care tool for the CANS, or a way of scoring it for Solano County specifically. But I actually think Medi-Cal will be a great point of reference for how to use these tools and collect this data, because that's what they're doing. It's my best understanding that at Kaiser we were supposed to be using the locus, but that's one of the deficiencies they found when they did that settlement, is that it wasn't being used. So maybe it's something the DMHC wants or has instructed agencies to use, but they're not, or I don't know what the landscape like that looks like.
Thank you. Additional comments, questions from committee members? Also noting we've got committee members attending virtually, just monitoring to see if we have any virtual committee members raised. Go ahead, Carmen.
I think one of the things that kind of hasn't been touched upon yet, but I know there's a lot of on the component on telehealth. I'm just curious as to how, this goes to the conversations that's been having, points that Sarah and Kieran have raised, which is like looking at how the spending is actually being spent and the quality of care. I think that there's some with telehealth, like, is it just spending a lot of money on an app to get a bunch of, so that we can just have a bunch of poorly paid therapists churn through a bunch of individuals? Like, I think it's a really important question to figure out, when we're looking at these big investments in behavioral health, what is the actual quality? And it's the same is true with involuntary inpatient treatment. Like, you can spend money, but like, is it actually necessary? And are we, let's not incentivize providers and plans to just dump a bunch of money into behavioral health that doesn't actually provide quality of care.
It's a good flag, and I think we can add it to our list of potential complementary analysis to think through, quality of care in telehealth, or how we might be able to better assess that. But, at least our investment and payment work group so far has recognized telehealth as an important access component to outpatient behavioral health services. So at this point, we're proposing to potentially include it in the benchmark for, outpatient type services for behavioral health.
I had a comment on the telehealth, and I kind of see two separate categories of telehealth. One being like at my current job, if somebody wants, a video visit instead of coming in person because they're currently admitted at a residential substance use disorder rehab in a different county, but they're going to need services through our county for behavioral health or mental health, that is kind of one kind of telehealth. And then the other kind maybe is app-based telehealth only kind of services. And I guess this was the thing that I was going to say that I keep forgetting. And this, again, is my own personal opinion and anecdote. But a lot of these apps, I get my LinkedIn and even just texts and calls, I get snowed in with offers to like talk to, I forgot all the names of these places, Grow, or I forgot, to become a therapist as part of their app-based therapy service provider. And the thing is the reimbursement, you have to get the higher end of the reimbursement, you have to work an inordinate number of hours. There's a lot of ways in which financially it doesn't make sense if you want to make a decent living with a good quality of life. And I think a lot of newer therapists or people who, especially in this economy, who, are desperate for work, may turn to that, but then find themselves very overwhelmed. And that's just in my personal experience talking with other therapists. And so I personally stay away from those platforms. But so I too have the concerns about the quality, and also the fact that, at least in our state, if somebody wants in person for whatever reason, that's what we should be providing. And these apps lock people into telehealth, and that's a concern, because sometimes someone doesn't have a safe place to, whether it's a child or somebody who is experiencing domestic violence, a safe place to privately speak openly, or their mental health is such that a telehealth is very difficult, or their Wi-Fi is bad, or whatever the reason. So not having the option to do in person is a concern of mine as well.
Thanks, Sarah. Really good considerations. And I think we can look into whether we can distinguish in the data between telehealth services provided by an in-network provider versus via an app or via some type of telehealth vendor. So we can look into that.
Thank you. We've got Sumana and then Ken.
Sarah, to your point there, this may be a temporary blip, but the sort of thing I'm seeing with this is a new phenomenon. This particular app is VC funded sufficiently that it's paying for the no-shows, paying for the cancellations. People are doing better. So in the short term, like Amazon and Uber, it could happen that therapist, and because I don't know if this is ever going to work out, but she's again bilingual and bicultural, and therefore she is being mobbed and providing traditional therapy and loving it. So I think there's a real danger that this could become the one option as opposed to an option.
Yeah, just one thought came to mind listening to Sarah's comments. With behavioral health, the individual really has no idea who the person is that they're being referred to, what their background is, what their specialty is. Is there going to be any way of somehow keeping track of people that start with one provider and then go to another one? From a quality standpoint, we just don't know. We know when we go to a medical doctor, we're going to an internist or urologist or what have you, but getting assigned to some mental health provider, you don't know what their specialty or experience is. So that's an area that just concerns me because it takes so long to get your first appointment. If you don't click, you got to go through the process again.
Thanks, Ken. Yeah, it's a good consideration, and we can look into that, whether there's a continuity of care lens that we could look into for behavioral health, or potentially the average number of therapy sessions with the same provider. Potentially, we can explore those types of metrics.
Parker?
A few meetings ago, I mentioned something called the special sauce in primary care. This is an analogy here. And I'm guessing Sarah will recognize it. I always tell my patients, I say, when you get to a therapist, as hard as it is, you're going to know in 7 minutes, maybe 7 seconds, and a good therapist will too, whether you will have a therapeutic alliance that will help you. And so the really tough thing to agree that the tough thing to measure in behavioral health from a primary care perspective is what's going on to really help support that patient to affect meaningful change. And so there's a special sauce as well in behavioral health primary care, and I have no idea how to really measure it, but Sarah and probably a lot of primary care people can tell you, like, it's really that instant connection. And when you find it with a good therapist, you know you're in a space where you've decided to trust that person and then make meaningful change that in the end produces health outcomes. But how we're going to count that, I think, is kind of that way complicated next level.
Joan?
Just to add one more nuance on the telehealth discussion, would encourage making clear that AI does not count. Because we are seeing chatbot telehealth for behavioral health coming, and it's just starting, but it's here.
No wonder they don't take insurance.
Sarah?
I guess this comment kind of talks about both the special sauce and AI, which is, well, one, most professional organizations like California or American Psychological Association, they have, codes of ethics, and like the APA has like a professional practices guidelines where it talks about, standard of care is not just what the research says, is the most efficacious treatment for this particular DSM diagnosis, but it incorporates a lot of different things like taking into account, patient preferences and cultural factors and all sorts of different things. And in one concern that I have about AI, not that maybe there is some use for it, maybe not at the psychotherapy level, but is when it comes to psychotherapy, even in theoretical orientations that are less using the therapeutic relationship as the intervention, it still is an extremely important part of the intervention. And for each different client, one thing that you may say in reaction to something a client says, or let's say, let me try to explain this. If one client says something, there may be a particular way to react to it that's appropriate. And if another client says the very same thing, there may be a different way from that first way that you used that would be appropriate based on their individual psychologies, personalities. You're using the relationship, transference, countertransference to develop an insight into what's going on and to provide interventions that are going to be helpful. So that kind of nuance, you may end up offending one client, saying the same thing you said to another client that is very helpful. And those very subtle differences are based off of your knowledge of the patient through the process of therapy, not just the content. And so I guess AI concerns me about not being sensitive enough to be able to do that.
Thank you. Additional comments, questions from committee members? Yeah, Ken?
Yeah, just one other thought is, with behavioral health, it might take a few sessions for someone to be referred to another level of individual therapy, or for example, a person may be seeing someone for a car accident, and then they're diagnosed with PTSD, and then they're referred to somebody else for EMDR type therapy or other therapy. In terms of the continuity, if there's a correlation, from level 1 to level 2, I don't know how that could be measured. But it's tough. At least medically, we know if we get referred by an orthopedist to an orthopedic surgeon, there's a logical conclusion that one got you to the other.
Okay, thank you. Additional comments or questions from committee members?
About continuity, the big problem that I see is people being funneled into brief psychotherapy without regard to what their actual needs are, and then repeated brief psychotherapy episodes with different clinicians, or maybe the same clinician, but uncertainty as to whether they can continue with that same clinician because it's not promised to be covered. So that kind of continuity is what I see more likely happening, and where the problem lies, including the problem with turnover as well. But like at Kaiser, they have developed all these treatment tracks, which are brief, kind of putting everybody into that. And if somebody doesn't get well in that brief treatment track, then they get maybe referred out via, it's not Beacon anymore, it's Carillon. So instead of just referring someone to a treatment that makes sense from the beginning, it's like, let's try them at brief treatment. If it doesn't work, then they go to longer term psychotherapy. But that isn't an appropriate way to triage people.
Thank you. Additional comments and questions from the committee? Okay. Yeah, Ken? There we go. Excellent. Well, that concludes this topic, I believe. This is the last topic on our agenda for the day, so we'll take public comment on both this item and we can go ahead and move to general public comment. So if you'd like to make a comment in the room, please step to the podium, and if you're online, please raise your hand. I'll give it a moment, but seeing no one stepping to the podium and looking online, noting for the record, we have about 60 virtual attendees, and seeing no hands raised for either this agenda item or the general public comment period. That concludes all public comment periods and takes us to the end of our meeting. We are adjourned. Thank you.